and then we go from there. It's really individualized, so it is helpful to have the score. That score does not tell you the whole picture. It doesn't tell you the family, the perspective of the family. I have a burden of, I have parents who have more disease burden in their children, so they're more aggressive about trying to start early. But then I do have parents where they're pro-treatment, but they're not showing signs. And those children we're watching very closely because I know any slight dip, they're going to want to go for treatment. But again, it goes back to not just looking at the numbers, and I think you expressed that a couple of times in your presentation. It's all of those parameters. But if there's something dominating the scene, we can't ignore it. There are children that are going to have more bone manifestations. So again, it's a comprehensive assessment, and we do suggest second opinions. I have a perspective, and I want the perspective in the area where you're very fortunate in this area to have Gaucher experts, and also behind the scenes, curbside and talking about it. And that's important for having relationships with other Gaucher providers to see what is their perspective. Is there something being missed? Is there something else that we should be doing? So I think in this day and age, we're very collaborative. It's not a hard and fast way to treat. Everyone is different, and we have to listen to you. You have to tell us what is your perspective and how are you feeling. So it's not just a number.
Dr. Grabowski.
Yeah, just let me give you a little perspective on how these were developed. I did not participate in the pediatric one. I did in the adult one. So you sit down with a group of, let's say, 6 or 7 experts in the field, and you start talking about what the most important things are that you want to find. And you use what's called the Adelphi method. After these pundits come up with these ideas of what's important, you go to the next level out in physicians who've had some exposure to Gaucher disease, and they then put in what they think are the most important aspects. And then finally you get out to a third or a fourth ring, and the idea is that you have sort of a collective intelligence on what are the most important things to look at, okay? So you end up with this score. To me, the most important aspect of this is that the patients get to an expert center, get diagnosed, and really get examined. The score, even though it's imperfect, is actually a reasonable way to say, this is how things should be tracked. And if we're not doing just that, we shouldn't be in this business. But at expert centers, you really need to have much more detail, much more attention to things. Now, inflammatory joint lesions like juvenile rheumatoid arthritis, like symptomatology or signs in Gaucher disease is quite rare. It occurs, but it's quite rare. And you know, you would think that if she had swelling of her joint and she had fluid and somebody tapped it and looked at the cells, they'd see Gaucher cells. Okay, they're there. But it is an unusual manifestation, so it's not surprising that it took a long time. These scores are not meant to be diagnostic tools. They're meant to be follow-up tools, scoring to see if things are changing inappropriately. Okay?
Does that answer your question, ma'am? Thank you. Yes, ma'am.
Is there any relationship, gender-wise, any gender relationship with how many children are born with the disease?
Perfect question for Dr. Lau.
So the gender relationship with respect to having the children, is that your question?
Male versus female being born with the disease.
Is there any gender selection? There is none that, as far as we know, I don't, and there's others in this room here, that there's no advantage or disadvantage. So you would think you'd see repeatedly a more predominant male or female affected with Gaucher, suggesting that there might be some kind of recurrent abortion of recurrent termination, spontaneous demise of children of one sex. We don't see that here. Certain other genetic disorders, we do see a predominance of one sex because the males are not making it to birth. But and I'm actually a neurologist, but as a geneticist.
No, it's equal males and females we see in Gaucher disease. So I would say that the disease itself does not, put weight on sex selection in utero.
Ma'am, can I ask you why you asked that question? Is there a personal context to that?
Nothing personal, just intellectual curiosity.
Okay. Thank you very much. I think there is a question at the back.
Okay, so I have two questions. Dr. Gaucher, I noticed you were working with mice, and hold on, leave that. I don't know what to say. Okay, so anyway, I noticed you were working with mice. I think that's wonderful. The chimpanzees are our closest genetic partners. Why not chimpanzees? I mean, because I think you might get better data. And also, what's happening with gene therapy? Okay, two questions. Thank you.
Okay. The reason we work with mice is that you can make a lot of them and they're cheap. Okay? And you can genetically manipulate them very well. And that's very important. The other aspect, of course, in academia is that they're really cheap. And it costs approximately, at the institution I used to be at, somewhere around 50 cents a day per cage to have mice, and you can have up to 5 mice, females, in a cage because the males don't get along. So that's one reason, but you can genetically manipulate them. But your question in terms of mice is highly relevant, and they are different than humans significantly. Not only, they're actually more different in the brain than they are in the viscera, but there are still differences. The brains are very, very different. Why not do chimpanzees, homologous monkeys or something? The cost is prohibitive. For the ability to do 2 monkeys and do some either genetic manipulations or give them certain kinds of drugs would be 1,000 times more expensive than it is in mice. It's enormously expensive. And then there are some issues around let's say the humanistic approach to monkeys because they are much closer, okay? But it's really the expense. And then the other thing is, let's say that you could make a Gaucher homologous monkey. It would cost a lot of money, and it would take forever to get enough monkeys to do anything. And you have to house these mice at $50 to $100 a day to keep these, I'm sorry, not mice, monkeys. Keep them around long enough to mature to what you want to do. So that is the major piece. The other thing about this is some people have suggested, why don't we make Gaucher pigs or other kinds of larger animals? And the problem with that too,
organ damage by free radical scavengers. And one such free radical scavenger is called N-acetylcysteine. And in this a study from Minnesota, they administered N-acetylcysteine, and the idea was that it would increase the production of brain glutathione to relieve oxidant stress. What is interesting about this study is I think it does indeed get to the brain. It does seem to increase glutathione levels and possibly reduce free oxidant damage. But this is research. We have a long way to go before its application in the human type 3 Gaucher disease. And so I want to end by saying that Brian Berman, Amy Blum, National Gaucher Foundation, we are dedicated to all forms of Gaucher disease, not just some types of Gaucher disease, for more than 3 decades. And this is a picture of Ariana. And Ariana presented with massive enlargement of the liver and spleen. And increasingly, we see these children, we can't decide, is this type 2 or type 3? And Ariana sadly has type 2, and with enzyme replacement therapy, she has grown. And she's giving a lot of joy to her mother. She's very happy. as you can see here, and we have to help these children around the world. And I think that the time is just right to see a quantum leap in our discovery efforts for treatment of these children. So thank you very much.
Don't go too far. Thank you, Dr. Mistry, for such a wonderful update and comprehensive update for Gaucher disease type 3. We promised that we would get to some questions. I'm sure we may run a little bit over the 3 o'clock time because we jam-packed our schedule today to give you as much information as possible. So I'm going to hand the microphone back to Dr. Mistry and have him moderate a panel Q&A. For all of those who are watching live stream on Facebook, we thank you very much. Post your questions in the comments section, and I will do my best to also include some questions so that we can try to answer them for you as well.
Thank you, Amy. So this is your meeting, so please ask questions. Yes, Robin.
Yeah, I was wondering if
Can we give you a mic, please? Can someone?
I was wondering if both you and Dr. Grabowski could comment on the role of glucosphingosine versus or in conjunction with glucose cerebroside in terms of the inflammatory cascades that we're all talking about.
Dr. Grabowski.
Yeah, we have to distinguish a little bit between glucose cerebroside, glucoceramide, and glucosphingosine as biomarkers. Okay, that's a different story. What we know about glucosphingosine, which looks like glucoceramide, but it's missing a fatty acid chain, okay, is it has really significant detergent properties. And because of that, it is an extraordinarily toxic compound to certain kinds of cells. Particularly if administered, let's say, in tissue culture to neurons, it kills them. Now, inside the cell, we're not sure exactly how that works, but it certainly participates in probably the inflammatory response. And there's a bit of conflicting data on these. Our data suggests that glucoceramide is a really important component of this, at least in macrophages and maybe even in the brain. Some of Tony Fuderman's data suggests that glucoceramide is an important compound, but we cannot ignore these very, very toxic effects of very small amounts of glucosphingosine. So it probably also will participate in that. If it kills off a cell somewhere, it elicits an immune response because the body is saying we can't have this. So it's probably an important compound.
Yes, ma'am. Can we give you the mic, please? Yeah.
All right. When the presentation of Parkinson's was given, there was one list that was that not normalcy of Parkinson's, not the signs. But they didn't say how it was identified if there wasn't a tremor or the other. They just said constipation and maybe a little dizziness or something. They never really told how they identified it with Parkinson's.
Thank you for that question. So in a meeting like this, everyone goes home, and because they're tired, they might have a little bit of tremor, and you get really worried. Are you starting to develop Parkinson's disease? So I want Dr. Alcalay to put this in perspective, please. Roy, please take a mic.
So currently we diagnose Parkinson's and treat Parkinson's based on the motor symptoms, which the most common would be tremor. It's easily identifiable, but shuffling of gait, slowness when things take longer than they should, stiff shoulder, frozen shoulder can be all early signs. The non-motor symptom battery often accompanies Parkinson's and help us make the diagnosis, but we do not make a diagnosis based on non-motor symptoms currently. It may help us in research that we conduct, both us and the Michael J. Fox Foundation, in identifying people that are at risk for the motor symptoms. So if one acts out their dreams or has lightheadedness when changing positions, and this is confirmed clinically, maybe they're at a little bit increased risk to develop a later motor Parkinson's. Now, very practically, the drugs for Parkinson's treat the motor symptoms. So currently, there's no reason to diagnose until the motor symptoms develop. But we do acknowledge that when motor symptoms develop, that part of the brain, 40 to 50% of the cells have already died. So there is an advantage, at least in research, to diagnose early. Okay.
Thank you, Roy. Yes, ma'am. You have the mic, please. Wait.
I'm curious about a couple things. One is the Gaucher severity scale. Is that something that's just unique to Mount Sinai, or is that used kind of broadly amongst all doctors who diagnose? And a couple of reasons why I ask this. Lindsay, my daughter, I'm pretty sure she's patient number 30 up there. She presented without all of the traditional symptoms of Gaucher. When I say traditional, her platelets or hemoglobin, are normal. Her biomarkers are going up. But at the age of 6, she started having severe arthritis joint pain. And we were told, repeatedly in our visits to Mount Sinai that had nothing to do with her Gaucher disease at the time. And I know there's been a lot of, since then, additional research about inflammation with Gaucher disease. So my concern in seeing that GSS, because one of our big things that we're trying to do is there are this whole realm of patients now, of children being diagnosed pre-symptomatically, if you will, based on their parents being carriers. And there seems to be a couple schools of thought as to when to start treatment. I know there are children who are starting treatment at 2 and 3 before they show symptoms. Lindsay, we ended up, her biomarkers were increasing. She never had any platelets or hemoglobin, issues, or, some of the more typical ones. But she had such debilitating, for 5 years, joint pain. We went somewhere else and started her on the enzyme therapy, and it got much, much better, after she was treated. And they did all this, and I also want to know, too, she clearly has some type of arthritis, inflammation issues. They did all the workups for rheumatoid arthritis. Everything always came back negative in terms of all of the inflammation, diseases, everything like that. So the only thing she has is Gaucher disease. And we know now that she's on ERT, it greatly helps her. So that chart, that scale doesn't mention anything about inflammation or joint issues. So I'm concerned that there's not a full picture. And the other thing I know is so many people with Gaucher disease present so differently. So how can we, I don't know, I just want to, and I know it's hard, and I know all these medical professionals are trying to do their best, but I still think we're missing something, and I still think, my sense is that if we know these children have it and ERT helps, I would recommend, because people ask, when should they start their children? And based on my experience, I wish she was started, many years before. So just kind of a general thing, and I'm curious to see where everybody thinks of that.
It's a very important question, Amy.
Thank you for your perspective. I think we should all be aware that there are huge and different perspectives coming out of the community. And I think that if there is significant joint disease that's impacting everyday life, then that would be something to consider. On the GSS score, there is that one column that is devoted to joint pain and bone pain. But I agree with you. You're coming from this perspective where your child is greatly suffering from this pain, that is not adequate enough to reflect what is going on day to day. I don't know about other centers, so I think, when I came on in 2012, I thought the GSS score was a nice way to keep me honest, so that I am consistent when I'm seeing patient 1 through whatever, that I am using the same criteria, the same
way of looking at the patient holistically and making sure that I'm not doing something different for each person. I feel that, you know, with different medical centers and different practitioners, everybody is different too. And they take their perspective from their clinic and the patient that they have. So I think sometimes it's worthwhile to understand from different perspectives. I think our clinic tends to have a majority of children who are very mild. And so the concern from out of my clinic is really, you know, we really don't want to start enzyme, and when, you know, how long can we sit on this information until we actually start? And so I know that your perspective is completely on the opposite end of the spectrum. And I think globally, I think we all as providers say that, you know, when making decisions about management and treatment, we encourage people to go out and seek second opinions, because I think that will then help in putting, you know, data together from different perspectives and at different centers and from different clinical experiences.
Dr. Heather Love.
I'll comment as well, since we're both seeing patients in the New York City area. So all centers, well, I'll speak for my center, we do categorize by severity based on multiple parameters. Whether or not we give you a number, I don't translate it to numbers, I talk to you. And on top of the numbers, then I talk to the parents about what is the...
And so there are two substrate reduction therapies, and basically they're both inhibitors of this enzyme, GCS, as I mentioned, Zavesca and Sadalga, shown here. And the difference here is shown in terms of these technical figures called IC50 for the two drugs. And that is a reflection of how potent and effective these drugs are in inhibiting this enzyme. So the lower it is, the better it is. So you can see the IC50 here is 0.024 micromolar, and for miglustat, IC50 is 20 to 50 micromolar. That tells you that Sadalga is a very specific and a powerful inhibitor of this drug. And the other thing it tells us that unlike Zavesca, Sadalga does not have any other effects in inhibiting enzymes that are not involved in Gaucher disease. And so I wanted to show you this figure because I think it is relevant to the broader discussion of type 3 Gaucher disease. This is the clinical trial of Sadalga, where patients taking placebo were compared with patients taking the active drug. And you can see the reduction not only in the inflammatory lipids, the glucocerebroside, the primary lipid that accumulates in Gaucher disease, as well as this lyso-GL1. You can see this really dramatic decrease, but also the inflammatory markers like the chitotriosidase and MIP1 beta. Tells you that inhibiting this enzyme, GCS, can reverse the fundamental disease process by decreasing not only the inflammatory lipids, but markers of inflammation. And we get this kind of inflammation and accumulation of inflammatory lipids not only in the liver and the spleen and the bone marrow, but also in the brain, where it has an additional effect in accelerating neurological phenotypes. And so a number of the substrate reduction therapies have undergone clinical trials, and this is one where they use Zavesca, led by Dr. Rafi Schiffman in Texas. And this controlled children who were stable on Cerezyme were randomized to receive either Zavesca or placebo drug. And I think here we are. This is the data conclusion that miglustat does not appear to have significant benefits on neurological manifestations of Gaucher disease type 3. But the study reported a very important signal in my mind, which is that it may have positive effects on lungs. and that led to greater decrease in chitotriosidase activity. That tells us that small molecule, unlike enzyme replacement therapy, is actually able to reach the lungs. And so for me, this was a very important piece of data to be bolder in terms of thinking about small molecule therapy for type 3 Gaucher disease. And so these are the limitations of current treatments for Gaucher disease type 3, and therefore children in the United States affected with this disease and around the world are suffering. Because enzyme replacement therapy, more than 95% of the uptake is in the liver, spleen, and the bone marrow. There's none in the lungs or to the brain. And substrate reduction therapy with Xedelga hasn't really helped us. So we need next generation Xedelga that can cross the blood-brain barrier. This is a seminal paper using Dr. Grabowski's mice, where they developed the next generation Xedelga. And in these mice, with neuronopathic Gaucher disease, it reduced brain Gaucher lipids, reduced neurological symptoms, and improved survival. So this is a very important piece of laboratory data to justify looking at this in patients with type 3 Gaucher disease. And so the LEAP trial is starting now, and this is a trial of the next generation Xedelga in combination with Cerezyme in patients with type 3 Gaucher disease who are older than 18 years or 18 years old. And the primary objective is to evaluate the central nervous system biomarkers in these patients and identify patients with type 3 Gaucher disease who would qualify for more extended treatment with this. And of course, with any treatment, you have to assess safety, because our fundamental operating principle is never to do any harm to the patient. And so safety will be evaluated with great deal of care. This will be a rigorous trial. It will involve spinal taps, blood work, and very extensive neurological testing to determine what is the effectiveness of this treatment. And there are a variety of secondary objectives. And those of you who are interested in this can look at this, Google this on clinicaltrials.gov. That gives a very detailed explanation. And these are some of the inclusion criteria. We are going to be studying, obviously, patients with type 3 Gaucher disease, but we also want to study patients with type 1 Gaucher disease and how they handle this combination treatment. And these are some of the inclusion criteria with respect to blood counts, liver and spleen volume, and it is important that these individuals are stable on enzyme replacement therapy for at least 3 years, and women who are of childbearing age must have a negative pregnancy test. And it is important that any seizures should be well controlled. And so the details, again, as I mentioned, is given in this clinicaltrials.gov a website, if anyone's interested, but please do reach out to the NGF for more information. There are some groups of patients who cannot participate in this study, those who've been on Xedelga or substrate reduction therapy, patients who've had their spleens removed and have severe liver or heart disease or kidney disease and so on. So this list is given here. We don't need to go over each of the detail. Suffice it to know that this study has been designed with a great deal of care to make sure that the safety of the patient is maintained. And moreover, after all that effort, that we get some useful data. So I would like to end in my last couple of minutes by really emphasizing that it is important to conduct proper clinical trials for maximum benefit for patients, to assess safety and effectiveness. You know, these poor families are very desperate, and they will take anything. And I think that it behooves on us, you know, not to start recommending all kinds of treatment based on weak data or anecdotal data. In my opinion, that is almost cruel, because you raise people's hopes and then only to find that there is no effect of treatment. And so the great thing is that there is a lot of a movement towards discovery of new drugs and new ways of treatment, but this should be done in a very disciplined way to obtain the maximum benefit for the patient. So among the exciting, interesting new experimental data that have come are the following, as I mentioned. So this is Dr. Brady receiving the National Medal of Science from President Bush for his lifetime contributions to Gaucher disease. And we are all here because of him, really. And forever, his passion was to help to contribute towards treatment for patients with type 3 Gaucher disease to achieve the same kind of transformative effect that he was able to catalyze with type 1 Gaucher disease. And in this paper published in 2011, and by the way, he was working in the lab only until the last month before he passed away a couple of years ago. And this paper used a drug that is normally available in cancer medicine. They are called histone deacetylase inhibitors. And he was able to show that this drug can bind to the Gaucher enzyme, and then even though there is the mutation, allow that enzyme to get to the lysosome and function normally. And so this and other work led to the concept that you can develop drugs that can chaperone abnormal enzyme due to mutation to make it work better. And so there is more work. Again, NIH has really made pioneering contributions to this, and this is the works, this is a paper summarizing the work that Dr. Sidransky's group has done, where they've developed really novel chaperones that are very specific for the Gaucher disease enzyme. And I believe Dr. Sidransky tells me that this is entering clinical trials now as well, or going through the process to begin clinical trials. So you're going to hear a lot about small molecule chemical chaperones, and the idea is that these medicines go into the cells, find the Gaucher enzyme, lock into it, and allow it to function normally. It's a beautiful chemistry concept. So I want to talk a little bit about Ambroxol. There is a lot of discussion about Ambroxol treatment. This is something that's available in cough mixtures in countries outside the United States. And so this is a paper from Japan where they gave Ambroxol on the basis that Ambroxol has the same kind of chemical effect in chaperoning as Dr. Sidransky's molecule, that and at the NIH it took a decade to develop those drugs. But in 5 patients, they felt that there was significant clinical improvement in these children with type 3 Gaucher disease. And so before I come to that, I want to say that, you know, patients, families that are affected with type 3 Gaucher disease, because they are so desperate and facing such terrible disease, there is a great temptation to contact their families and friends in Latin America, Canada, elsewhere, to get bottlefuls of Ambroxol and start taking it. And I think that it is important that we temper expectation because, you know, this kind of issues can really present very major challenges in taking care of a sick child. And as I mentioned, it is important that these drugs go through the same kind of rigorous examination as we did over 10 years with Sardelga clinical trials. Finally, this is a very interesting concept, in my opinion, as well. And this arises from the idea that there is a lot of free radicals generated due to inflammation in Gaucher disease, and that you can ameliorate and had onset after 2 years. And this was a very similar cohort to the study that we recently published on the long-term outcomes with Cerezyme treatment. So this is what Dr. Kolodny and his colleagues found when they looked at the onset of neurological symptoms, the age at the onset of each of these things, like difficulty in breathing, swallowing difficulties, holding toys, muscle weakness, walking difficulties, chewing difficulties, and so on, difficulty with gait, speech, spasticity, seizures, and so on. And what you can see here is that earlier on, the neurological signs can be quite subtle. So it can take quite a few months before the diagnosis is established. And it is quite late that you begin to see seizures and very disabling neurological symptoms. And so the natural course of neuronopathic manifestations was mapped out in this study. The early symptoms are shown here from birth to 2 years. And you can see there is a prominent enlargement of the liver and the spleen, wasting, low blood counts. But in addition, there are a variety of neurological symptoms shown here. And then in the second phase of the study, of the disease, there is greater seizure activity, myoclonus, spasticity, and neurological disability, with final phase of the disease when the child is absolutely disabled. So I wanted to show you a picture of this child that Dr. Grabowski, Dr. Kolodny, and I saw about a decade ago in Egypt through our work on the humanitarian program. In Egypt, it is like the intensive care unit of Gaucher disease. All of the children are like this. And in his talk on inflammation, Dr. Grabowski talked about inflammation. You see, this is a picture of florid inflammation and activation of metabolic state. You see, this poor child has no muscle, no adipose tissue. And I remember vividly the day we saw this child, we walked away from the bed thinking this poor child was not going to survive another day. With this extreme enlargement of the liver, the spleen, and how pale this baby looks. And so in our study, we found that children were anemic. Their platelet count was low, but not incredibly low, but their liver and spleen were massively enlarged, and these children had quite severe growth failure. And so we now have data going on from enzyme replacement therapy for many years, in fact, and that has shown that there is reversal of low blood counts, the liver size gets back to normal, spleen size also improves dramatically, and there is an improvement in growth parameters. And so this is him now, recently, having had treatment. This is the same child who is now growing up. Just goes to show that the enzyme replacement therapy can be truly life-saving and transformative for these children. Still, we have challenges. So when you plot this graph called the Kaplan-Meier curve, it's a technique to look at the survival probability with time, with age, and you can see that the survival probability at 5 years is 92%, 10 years 82%, and at 20 years 76%. So this remains a life-threatening disease. All we've done with enzyme replacement therapy is to move the end point of the disease a bit further out. Yet these children are looking to a life of disability and significant chronic ill health. And so these are the current challenges in type 3 Gaucher disease. progressive neurological disease, which is variable, progressive lung involvement, and massive enlargement of lymph nodes in the abdomen, and spinal deformity, as I showed you. And there is a type of type 3 Gaucher disease where there is involvement of the heart with cardiac calcification, and so on. So these are compartments of the body where the enzyme does not get through. Because when you have your enzyme infusion, vast majority of it goes in the liver, the spleen, and the bone marrow. There is no enzyme left to go to the lungs or the lymph nodes. And so in type 3 Gaucher disease, these are the aspects. And of course, enzyme treatment does not cross the blood-brain barrier. And so we have a number of patients in the United States with type 3 Gaucher disease, and I'm going to talk to you about three children, and they are truly inspiring stories. This is the first child. This is Stephen. He's now 10 years old, and I've looked after him since he was 1 year old. He was diagnosed with Gaucher disease at age 3, massive enlargement of the liver and spleen, low blood counts. He had 2 copies of this mutation that I called L44P and started on Cerezyme at age 3. His IQ is more than 130. He's at the genius level, approaching quite close to this. Currently, he's doing Singapore math, which is I'm told, very challenging curriculum. He has diagnosis of ADHD and autism. And in fact, recently, workers are beginning to recognize that part of type 3 Gaucher disease is a behavioral abnormality, which is important to recognize because you can then treat these children appropriately. So I'm hoping that somehow I can get this video to just show you how gifted Stephen is. Okay?
Number 5 in D major, octave 22, third moving.
Volume.
Hope you like it.
Type 3 neuronopathic Gaucher disease. Just think about that. So this is the second patient, Tylen. And Tylen is now 12 years old. Again, I've looked after him since he was a baby. 2 copies of the same mutation that Stephen has. And recently, he started to lose a lot of weight after having done really well. And I just read a paper of Dr. Grabowski where he had described an unusual manifestation of Gaucher disease, which is massive enlargement of lymph nodes in the abdomen to the point that it can really begin to strangulate intestines. And when we did Tylen's abdominal MRI, CT scan, this is what we found. Huge lymph nodes which were calcified. And he has lost a lot of weight. He'd been on enzyme treatment since age 2 and has done really well, but this is a life-threatening disease, and we need to fix this. Fortunately, the FDA gave us an individual, what's called an individual IND, to add in Sadelga to his treatment in the hope that that medicine can get to the lymph nodes in the way that the enzyme treatment cannot get. And hopefully we will be able to help this child. This is Tylen. You would never guess that he faces mortal danger. And there are many children like this around the world and also in the United States. All right, so as you've heard, enzyme replacement therapy is a way to replace missing enzyme. But as Dr. Grabowski pointed out, the lipid that builds up, the fatty material that builds up in the cells of the body is essential. Without it, you can't live. It's a bit like cholesterol. Without cholesterol, you cannot survive. In the same way, glucocerebroside, the lipid that builds up in Gaucher disease, is essential for survival. And so the body has a way to synthesize this, and under normal physiological equilibrium, also have a way to turn it over and break it down so that there is a physiological balance. In Gaucher disease, two things happen. Number one, there is a deficiency of the enzyme, so the lipid builds up. But Dr. Grabowski had a very important piece of information in his presentation. He talked to us about inflammation. And one factor that was driving that inflammation was that there was increased production of the glucocerebroside enzyme. And there is a convergence of data that is starting to show that in Gaucher disease, in addition to the deficiency of the enzyme, there is actually an increased production of the lipid that is so harmful. And so when you have enzyme replacement therapy, that treatment is directed to the macrophages, and it makes up the missing enzyme in the macrophage system to achieve a physiologic equilibrium. With substrate reduction therapy that affects all cell types of the body, including the immune cells that Dr. Grabowski and his team has identified, it reduces the rate of production of this lipid to restore a new equilibrium in the cells. And so this understanding of the difference between enzyme replacement therapy and substrate reduction therapy is important for the evolution of the next level of therapy, not only for neuronopathic disease, but also for Parkinson's disease. And so, as we've learned today at this conference, inflammation is at the very heart of Gaucher disease. The fatty material, the lipids that accumulate in Gaucher disease are causing inflammation. And this is a type of inflammation that is called the sterile inflammation. We normally know about inflammation as what you experience after you have a flu infection or pneumonia. Here there is no infection. It is what is inside your body that is causing inflammation. And it is involving some ancient immune pathways like the complement that he described. So inflammation increases the enzyme that makes more lipid, glucocerebroside, and this enzyme is called GCS. And SADALGA slows down the activity of this enzyme, GCS, okay? And so this factor that amplifies Gaucher disease can be controlled by drugs that can inhibit this enzyme, glucocerebroside synthase. I'm too scared about this issue because it's only 4% of patients with Gaucher disease who develop Parkinson's disease. But the great news is that so much research is going on to help and identify that 4%. And that is a sign of really quite an extraordinary evolution of the field. Being here today, I feel I'm in with my extended family, so thanks very much for this opportunity. As Amy mentioned, I'm going to be talking about giving you an update on what is happening in type 3 Gaucher disease, because the National Gaucher Foundation advocates and supports all of Gaucher disease, not just a certain type of Gaucher disease. These are my disclosures. And so the topics that I'm going to cover today includes a discussion that Gaucher disease is really a very important global disease. Second, we'll discuss the long-term response to enzyme replacement therapy. And we have now data on children with type 3 Gaucher disease that have been on treatment for 15 to 20 years. And then discuss what are the big health challenges that these children suffer from. Type 3 Gaucher disease remains a disabling and a life-threatening disease. There is progressive lung disease, progressive spinal deformity, and there is progressive enlargement of lymph nodes in the abdomen that can cause compression of the intestines, and of course, variable degree of neurological signs. There is now new hope for these families that suffer from type 3 Gaucher disease, and there is a clinical trial that I'm going to be giving you an update on of a small molecule, the next generation of Sodelga, that can actually cross the blood-brain barrier. And so, as you know, Gaucher disease, there are 3 broad types. We've been talking quite a lot about type 1 Gaucher disease, but these are the more devastating forms. The type 2 that is recognized in the first months after birth, and it is devastating. These babies are very, very sick, often in the intensive care unit, and sadly, these babies do not survive beyond the first year of life. And then there is type 3. It involves milder degree of neurological involvement, and the onset can be in early childhood, and many of these patients survive into adulthood, even until their 4th or 5th decade of life. But there is a variable degree of neurological problems in this patient population. So the story of type 3 Gaucher disease began in northern Sweden, in this part, Norrbotten. And there, the first cluster of Gaucher disease patient population were recognized by some pioneering researchers, Dr. Lars Svennerholm and his colleagues working in the 1980s. And they actually came and gave a series of presentations at a very important meeting in New York City that Dr. Greg Grabowski organized. And that meeting was published as a book called A Century of Delineation. And that is a textbook on which I learned all my knowledge about Gaucher disease, and so many of the things that Dr. Grabowski articulated in that book are still relevant. And so in Norrbottnia, in northern Sweden, these were the kind of children and young adults there were. So these were children, as you can see, very, very sick, with massive enlargement of the liver and spleen, abdominal distension. The other thing Dr. Grabowski mentioned is the cytokine storm. It's as if the body is on fire, and so these babies are losing all of their adipose tissue. You see how the muscle is wasted, and there's no adipose tissue. And sadly, these children died very, very young. But here is an adult who has survived into adulthood, but you see how that there is spinal deformity and this deformity of the chest wall as well. And so this is a very variable disease in one part of the world, northern Sweden, a small community, and there is extreme variability from onset into adulthood and fatal disease in childhood to someone who is able to survive into adulthood. And you could see this even in a single family that had multiple individuals who were affected. So the most extraordinary thing is in northern Sweden, people give very good genealogy. And they were able to trace all of the individuals who were affected. These are the filled circles and squares with Gaucher disease, called the Norrbottnian Gaucher disease, to one ancestor, shown here, living in 1651, 1653, and even their names are given. And yet, the disease is so variable. And Dr. Amy Yang talked about N370S Gaucher disease homozygous, and only 3 or 4 of the 35 children were affected. We see the same phenomenon of variability in what we call the phenotype or disease expression in this population as well. So a very important concept that has been developed by Dr. Ellen Sidransky for more than the last decade is this, that really Gaucher disease is a continuum. So we have type 1 at one extreme, then type 2, the fatal disease at the other extreme, and so there is a continuum of phenotypes with some of these main manifestations that we've been talking about. It is sometimes helpful for us in the clinic to think in terms of the concept that essentially Gaucher disease leads to multiple syndromes, even though the underlying defect is a single gene and a single enzyme defect. And so it is possible to recognize, for example, Gaucher disease and Parkinson's disease as a specific syndrome. And the reason I say that if somebody in their 40s or 50s develop Parkinson's disease, you would expect they would have commensurately severe Gaucher disease, big liver, spleen, low blood counts. The answer actually is that there is absolutely no relationship. And in fact, somebody with very mild Gaucher disease can present with Parkinson's disease. Same thing applies to devastating occurrence of multiple myeloma in Gaucher disease, and so on. And so I think it is very helpful when we see the patient in the clinic to try and understand the nature of the disease in the individual person. And for type 3 Gaucher disease and the neuronopathic Gaucher disease, already we can recognize distinct syndromes from the type that is evident at birth with skin abnormalities, and that's something that's been described actually by Dr. Sidransky and her group, where these babies do not even survive the first day of birth, to the more relatively milder varieties called type 3A and type 3B disease. And so the ICGG registry is a wonderful resource to look at Gaucher disease across the world, not just in the European population. And what we've learned in looking at more than 4,000 patients is that if you have this one N370S mutation, this is an ancient mutation that occurred in the 10th century in Eastern Europe, and it has spread through the European world. So it is very classically Ashkenazi Jewish mutation. A lot of us believe that there may be a selective advantage associated with this because the carrier frequency in Ashkenazi Jewish population is nearly 1 in 15. So if you have 1 or 2 of this mutation, that absolutely guarantees type 1 Gaucher disease. What I'm going to be talking about is this type of Gaucher disease. And you see N370S does not occur in type 2 or type 3 Gaucher disease. It is mostly characterized by 1 or 2 copies of this mutation called L44P. What is interesting about this mutation is that it normally occurs in an ancestor gene of the Gaucher gene that is active at the moment. And so this gene locus is kind of genetically a little vulnerable in terms of passing that mutation onto the active gene. And therefore, this mutation occurs in every population, not just in the European or Ashkenazi Jewish population. And therefore, you would expect this kind of Gaucher disease in East Asia, in Africa, Middle East, and other parts of the world. And so the literature, the world literature is predominantly European-centric. So it is focused on N370S mutation, which arose in Eastern Europe. And so 95% of the literature, I would say, is focused on type 1 Gaucher disease. The reality is that the biggest burden of Gaucher disease is due to homozygosity, 1 or 2 copies of this alpha-4p mutation, which leads to the most devastating forms of Gaucher disease, type 2 and type 3. And so we really need to address the global distribution and have a better understanding and offer something for individuals affected with this devastating forms. And indeed, even in the United States, we have some patients with type 2 and type 3 disease. We believe that of the total Gaucher disease patient population, children with type 2 or type 3 disease are about 5 to 6 or 7%. So the International Gaucher Registry has done a number of important studies. This is a type of Gaucher disease where there are very few patients in single centers. So the International Gaucher Registry, led by Dr. Ed Kolodny and colleagues, have done a study involving really 131 patients to study what are the neurological complications that these children suffer from. And recently, earlier this year, we published a study involving 253 children who received enzyme replacement therapy with Cerezyme for up to 15 or 16 years. And this study was focused entirely on children under the age of 18. And I'm going to just discuss the key data from these 2 studies. And so the neurological outcomes registry involve children with a mean age of 3 years, and the onset of neurological manifestations was less than 3 years in about half the children, and about 40% of the children.
By the NIH, the Parkinson's Disease Foundation, the Michael J. Fox Foundation, and the SMART Foundation. So if I could direct your attention and ask Dr. Aglaya Menaled to please come up.
Can you put on the slide or? Okay, thank you. I would like to thank the organizers for inviting us. We're going to be very brief. The major purpose of our talk is really to highlight the link between Gaucher and Parkinson's and maybe open up for discussion that will come up later. I could have talked about the topic for hours because that's what I do for a living, but it's really just a glimpse into the link. So just very briefly, Parkinson's disease is a common condition, different from Gaucher disease, of course. Roughly 5 million people worldwide. The estimation is roughly 1 million people in the United States are affected by Parkinson's. And it's the second most common neurodegenerative disease after Alzheimer's. It's age-specific, so the older you are, the higher the risks for Parkinson's. And above age 60, roughly 1% of all people 60 or older have Parkinson's disease. If you looked at 80-year-olds, it's probably 4%. Now, Parkinson's is most known for the motor symptoms, and the motor symptoms include a tremor at rest, which is very specific for Parkinson's, but most patients with Parkinson's don't exhibit the tremor at a certain moment. There is slowness of movements, rigidity, stiffness of muscles, and issues with balance and gait. In more recent years, the non-motor symptoms have received more traction, including cognitive dysfunction in people with Parkinson's disease, depression, anxiety, impaired sense of smell, sleep problems, including acting out one's dreams. Up to 70%, if not even more, of people who act out their dreams, which we call REM sleep behavior disorder, will progress to develop Parkinson's disease or a syndrome similar to Parkinson's. And there's also autonomic dysfunction, which is associated with Parkinson's, which means constipation or lightheadedness when changing positions from sitting to standing. So we can think Parkinson's disease is associated both with Gaucher disease and with a carrier status. So the healthy family members that do not have Gaucher but carry the Gaucher gene also have a little bit increased risk for Parkinson's. What's the risk in Gaucher patients? The best study, the largest to publish, that has been published to date, came out of the registry, and it estimated the risk for Parkinson's among Gaucher patients at 5 to 7% by age 70, and let's say roughly 10% by age 80. So still 90% of the patients by age 80 did not have Parkinson's, but it's higher than the 2% in the general, 1 to 4% in the general population. When people queried their own practices, they reported 2.5, 2.2% of Parkinson's in the practice, but we need to always adjust it for age because Parkinson's is age dependent, and the older you are, the higher the risk for Parkinson's. What was groundbreaking in the Parkinson's world is to identify that even Gaucher carriers, and which is a very common state, especially in the Ashkenazi Jewish population, is a risk factor for Parkinson's disease. We tried to estimate what is the risk of the Gaucher carrier to develop Parkinson's, and the estimations worldwide are very variable. A study in Ashkenazi Jews that came out of Jerusalem and Mount Sinai estimated it at about 8%. A study from France looking at Parkinson's families estimated the risk in carriers 30%. So as you see, there's a lot more that needs to be done in estimating what's the risk for Parkinson's in Gaucher carriers. And as in everybody else in the population, the risk is higher in people who are older and in males in men compared to women. The risk in Gaucher carriers is also higher when one has a severe mutation like 84GG and Del44P compared to the more common mutation N370S. So this slide basically would say that there's not that we don't know much about how to prevent Parkinson's, how to slow down its progression. People would often ask if enzyme replacement therapy reduces the risk for Parkinson's. We do not know that. Most of the enzyme replacement therapy is available today does not cross the blood-brain barrier, and as far as we know, does not decrease the risk for Parkinson's. One would argue that because of the longevity it provides, it maybe puts more people at risk because they live longer, so it does a good thing this way. Other medications, most Gaucher medications do not penetrate the brain, but because of the link between Gaucher and GBA and Parkinson's, there's a major effort to develop compounds that will penetrate the brain and may help both those with Gaucher disease that affects the brain, Gaucher type 2 and 3, and the risk for Parkinson's in Gaucher patients and carriers. Currently, when we treat people with Parkinson's, we do test, at least at Columbia University, genotype them to test if they're Gaucher patients or GBA carriers. One of my patients who participated in my study discovered this way that she's a Gaucher carrier. She planned to come today, but had to cancel because of a family event. And I think to finish and to pass the microphone to the Michael J. Fox Foundation, there's a lot of hope in research. It's really changing the field of Parkinson's. We are very hopeful that by understanding the link between Gaucher and GBA carrier status to Parkinson's disease, we will be able to treat both this condition and general idiopathic Parkinson's disease. Currently, if you looked at a website like clinicaltrials.gov, you would see that there's 3 clinical trials worldwide looking into the link between GBA and Parkinson's, for which we genotype people with Parkinson's to see if they're carriers. If they are, they're eligible for the study. And Liliana will talk about the Michael J. Fox effort to better understand the link.
I want to thank you again to Amy and Samantha for inviting us. At the foundation, we're thrilled to be able to partner with the National Gaucher Foundation. And I also want to thank you, Roy, for always supporting our efforts. So I am presenting here on behalf of the foundation. I'm part of the scientific team at the Michael J. Fox Foundation, which is the world's largest non-profit funder of Parkinson's research. The foundation is dedicated to finding a cure for Parkinson's disease and ensuring that there's a development of new and improved therapeutics for those that are living today with the condition. Since the foundation was founded in the year 2000 by the actor Michael J. Fox, we have funded over $650 million in research programs. And these research programs aim to that are aligned to our mission, which accelerate therapeutic development. We really want to run out of business. That's our motto. We want to cure the disease and close our doors. So the programs that we try to fund are those that are, for example, aiming to help us understand what are the sequence of events that trigger the disease, or all actually therapeutic programs per se. These programs take place both in industry as well as in academic institutions in the US and around the world. And another area where we invest a lot is also the discovery of new biomarkers. A biomarker is a substance or characteristics in our body that you can measure objectively and is associated with the presence of disease, or that changes with time in a way that is linked to the progression of the disease. For Parkinson's, we don't have that. And to evaluate therapeutic tools that can slow the progression of the disease, we will need to be able to see, to have a biomarker of progression, to have efficient clinical trials. And with this domain of biomarkers, we have our largest initiative, which is the Parkinson Progression Markers Initiative, which we call it PPMI for short. PPMI is a landmark study for us. It's an observational study that we are the sponsor of, that aims to understand, to discover new biomarkers or the biomarker for Parkinson's disease. There's over 1,000 individuals enrolled. Most of them have Parkinson's disease, but of course, many of them don't have Parkinson's disease. And this is happening around 33 clinical sites all over the world. Again, the aim of this study is to identify the biomarker, to help with the diagnosis of the disease, to have better and earlier diagnosis, to help tracking disease so the patients can get the best medication associated with the presentation they have. And also to have more efficient clinical trials so we can be able to uncover disease-modifying therapy. Now, PPMI is a study in which patients don't take drugs, but industry is very interested because they need these biomarkers. And there are 20 companies that are partnering with the foundation with funding that are helping us to move this forward. This is an $80 million study. The data we collect is our motor testing. So these patients undergo a battery of motor testing, cognitive testing, neuroimaging, and we collect also many different types of samples like urine, blood, cerebrospinal fluid. And all those biosamples then are analyzed by top researchers. And all the data we collect is open to the community, so they can mine the data and help us find biomarkers. And the last thing I want to say about this study is that within this group, there's a cohort of people that have the GBA mutations. Some of them have Parkinson's disease because we're interested to understand how a Parkinson patient with a GBA mutation looks like and how he progresses with time and changes his disease with time. And also we have a group of people that have the GBA mutation and do not have the disease because we want to understand what protects them. If we understand that, we think we can maybe uncover new avenues for therapeutic development. And if you're interested in learning more about this, you can check our website or call this number, and everybody will be very happy to answer any question. Thank you.
Thank you so very much. We can tell my height is an issue compared to many of the other presenters up here today. Before we get to our Q&A, we have Dr. Pramrod Mistry here, and I had asked him if he would give an update for our audience on type 3 Gaucher disease and research that's going on. Dr. Mistry was born in Kenya, and he grew up in England. He received his PhD from St. Thomas's Hospital Medical School and MBBS from the Royal Free Hospital School of Medicine. Dr. Mistry's clinical research and educational activity center, they center around inherited metabolic liver diseases and in particular on Gaucher disease. He began caring for Gaucher patients in 1988 and since that time has cared for over 500 Gaucher patients. He is the professor of medicine and pediatrics at Yale School of Medicine and the director of the Yale Lysosomal Disease Center and Gaucher Disease Treatment Center. Dr. Mistry proudly serves as the patient population, through membership in the advisory boards of the National Gaucher Foundation and Project Hope's humanitarian program for children of the world suffering from Gaucher disease. Dr. Mistry.
Thank you, Amy, for that very kind introduction and the opportunity to participate in this meeting. And I have to say, I think that this is a really momentous meeting with a discussion on Parkinson's disease, and I'm going to be talking about type 3 Gaucher disease. And as I was listening to the Parkinson's disease presentations, I was reminded about something that Dr. Sidransky cautions, that patients shouldn't be.
We wanted this child to reach expected height. And so patient number 25 was started on enzyme replacement at age 9 at another center. And from the report at another center, the patient and the family were concerned about the growth delay, and again, not meeting the mid-parental height, and also moderate hepatosplenomegaly. And then patient 30 was also recommended to start at another center due to concerns of poor linear growth and joint pain. So from this slide, you can see one thing that they all share is the concern of growth and linear growth. So that's a commonality that we have been able to pick out from these 4 children. It is important, I want to say just a quick note that, again, we're not just saying height here, but there had to be other things involved for the family and the clinician to both make that decision, to make the leap and say, okay, let's start enzyme replacement. And it's usually not just that one visit, it's usually subsequent visits. And so, and then that's important for all of us to consider when we're talking with our teams and our family. And, it's never an easy decision to start enzyme replacement. I think, given all of concerns, these are school-age children, right? So there's school and schedules, and then it's changing the life of that child. It's starting in an IV therapy for life. So this is not an easy decision by any means, and there's a lot of discussion that needs to go into it, and a lot of things that we have to do to push us as physicians and push us as parents to make that decision, right? Okay, so the other thing we've been doing, because the major concern is height. We wanted to make sure that there's nothing else besides their Gaucher disease that's contributing to the decrease in height expectations. And so we sent these children first to an endocrinology consult to rule out any other causes of short stature. And because if you're saying that you're going to start enzyme replacement and we want to expect an improvement in height percentile, we want to make sure that we are treating the right cause. So really, this is an important thing that we do before we start enzyme replacement, to make sure that there's nothing else at play. Okay, so a quick summary. For children with N370S homozygotes and for children who are N370S R496H, we can say comfortably that yearly screening with an exam, CBC, Chido, and abdominal imaging, and then every other year with a DEXA scan, it seemed adequate. We're able to pick up these children as they're developing their symptoms, and we're able to recommend treatment in a timely fashion. The majority of these children will not display any signs or symptoms, or only few symptoms of Gaucher disease in childhood, and a majority will not need treatment in childhood. So hopefully we're able to start to answer some of these questions that these carrier couples, these families are bringing to us. And just want to summarize, the first sign of disease in these group of patients seem to be that they're not meeting the mid-parental height expectations. The next step was mild osteopenia, and the last that we were able to pick up was mild splenomegaly. Okay, and then I just want to put it out there because, everybody wants to say, when should we start? Is there a particular number? And there isn't, but I would have to say, looking at our 38 patients and then comparing the 4 that were started on enzyme, and then looking at those dots, it does seem that, perhaps Kaido and Gaucher severity score may help in how we see the patient as a whole and make that decision. Okay, and then of course we have limitations, right? This is a very small group of children whose genotype is very, very similar, so very homogeneous. And there is an ascertainment bias. These are cohort children whose parents underwent carrier screening. So then we're not picking up the rare variants. So when we are doing prenatal carrier screening, it's called genotyping, and the lab is only picking up very specific mutations that have been seen over and over again in the population. So they're not looking at the entire gene here, right? So we're going to be, because of this, we're only picking up through these methods carrier couples who have these mutations and not more rare ones. So we do not have, the other thing I find interesting is that we don't have any pre-symptomatic children with genotype predicted to be more severe. So this is your N370S, 84GG, and other compound heterozygous combinations. So I can't really say how these children and their follows are going to be, but in general, I would expect these children to be more severe and present earlier than the data that I presented. And it's curious why we're not seeing that. It could very well be just there's a preponderance of N370S alleles in New York City area. I don't know. But I think what I love about this cohort, it is homogeneous, and we could say a good amount of information about people who are homozygous for N370S homozygous. And I think then that will hopefully drive the way we follow these particular patients, but also, it highlights the need that we need to follow children who are N370S plus other alleles in a similar fashion, so that we can be more informative for all our patients going forward. And so we really need, concise but large group of patients and children followed from the beginning with very similar genotypes. And I don't know how we're going to be able to do that, but newborn screening is coming along, as some of you guys have heard, within 4 states, and perhaps that might be a way in which we could find out more information for you guys. Okay. And then there is a wide variability of Kaido triadase amongst children in the same group and also within the same family. So we do see that. And we don't know whether there's going to be better biomarkers out there. Hopefully, I know a lot of people are looking at this particular one. It's called lyso-GL1, but it's still in the very early phases, and so that's to be determined. And not all children are able to undergo the recommended assessments because, we're very practical in the sense that we don't like to draw too many attempts. If the first time we don't get the blood, we don't try and poke the child too many times. It's not comfortable for any of us. The problem with MRIs, it does require children to undergo sedation, so we try to balance the risks and benefits of that. And there's no normative data for DEXA scan in younger children, and at some centers, including ours, we don't do DEXA scan below age 5. So that might be important for not the N370S homozygous population, but maybe it would be some data that would be very enlightening for patients with more severe genotypes, but we don't have that capability. Okay. Other pediatric considerations, Dr. Lau had mentioned vitamin D. So we do measure vitamin D, and we do supplement. And then the other thing I want to point out there is sometimes a concern with CMV and EBV. These are particular viruses that can cause the spleen to be quite enlarged. In the older terms, we call this mono infection. And so if you guys, remember from your teenage years, if, sometimes people talk about mono and it can happen in the high school years, most predominantly, or in college, but it can happen in younger children as well. So I just want to show you these 4 children who were starting on enzyme. What's important to know that patient 17 actually had an EBV infection. So I just want to sort of compare this child to the rest of the group, because look at his GSS score. It was elevated from the very beginning. At age 3 it started because of that EBV infection. And it's unfortunate. And, so it seemed that perhaps this is one of the reasons why a child can present earlier than the rest of the pack, because of an EBV or a CMV infection. So if you have a child who is exposed to EBV or CMV, please contact us so that we could seek proper care and make sure that the liver and spleen is doing okay, and that they're doing okay, all right? And then I'm sure we'll have that question coming up, okay?
Thank you so much, Dr. Yang. So we're running a little behind, and since we're so tight on the schedule, while we are having our entrees cleared and desserts served, I'm going to continue with the program so we can try to stay on target. And I hope that it won't deter so much from being able to listen along. So very excitingly, the National Gaucher Foundation has recently begun to collaborate with the Michael J. Fox Foundation. And the Michael J. Fox Foundation is doing some groundbreaking work in terms of Parkinson's disease, but also looking at the GBA gene. So for individuals who are Gaucher carriers, as well as Gaucher patients themselves. And today we're fortunate enough to have 2 physicians that are associated with this particular research out of the Michael J. Fox Foundation. One is Dr. Liliana Menaled. Forgive me if I've pronounced it incorrect. Got it? Okay. And she is, I only know her as Liliana when we just have conversations. She is part of the scientific staff at the Michael J. Fox Foundation. And her responsibilities include ensuring that the priorities of the foundation reflect and best serve the ultimate needs of patients. She stays closely linked to the Parkinson community and to help develop an aggressive and innovative agenda for accelerating research and drug development for Parkinson's disease. She leads the foundation's priority interest in understanding GBA, a major risk factor for Parkinson's disease. She received her pharmacy degree and PhD from the University of Buenos Aires, Argentina. Our second doctor who will be presenting with her is Dr. Roy Alcalay. Dr. Alcalay is the Florence Irving Assistant Professor of Neurology at the Taub Institute and the Program Director of the Movement Disorders Fellowship at Columbia University Medical Center. He obtained his medical degree from Tel Aviv University in Israel, his neurology training from the Harvard University Residency Program at Mass General and Brigham and Women's Hospital, and his movement disorders training at Columbia University. His research focuses on biomarkers and genetics in Parkinson's disease and cognitive functioning. He is a Brookdale Leadership in Aging Fellow, and his research is supported by
what we call compound heterozygotes for N370S and R496H. So for those of you who do have this genotype, we actually have 14 patients with this particular genotype at Mount Sinai. 6 are children and 8 are adults. And what I can tell you is so far none of these children to date, and their mean age right now, these 6 children are age 7, and none of them had elevated chitotriosidase so far, and so far have remained asymptomatic. And also, only 2 of the 8 adults were diagnosed with Gaucher due to symptoms. Their mean age at diagnosis was 39, and they are now on enzyme replacement therapy. But 5 adults out of the 8 were diagnosed incidentally through prenatal carrier screening. And 1 adult was diagnosed after a family member had direct-to-consumer testing. So this sort of supports the idea, our numbers sort of support the idea that the N370S and R496H in combination is a very mild Gaucher disease. Okay. So this is some of we'll go through now some of the data that we see in these children in terms of lab work and studies. So the hematological findings so far, I can tell you that none of the children had anemia, and the majority of children have mild to normal platelets. So that's a cutoff of 120. So the laboratory will flag something abnormal or low platelets at 150, but we also know there's a lot of people in the general population who could have mildly low thrombocytopenia or low platelets. So this is why we kind of group mild normal together at this cutoff. And the majority of children that we saw do not have any major issues with their platelets. 95% fall in this group. And only 2 patients have mild thrombocytopenia, so that's between 60 and less than 120. And none has severe thrombocytopenia. So hopefully that some of this data will be reassuring to you guys. The liver and the spleen volume, we do multiples of norm after it's seen on ultrasound. And so again, for the spleen, it's on the bottom here, majority of children do not have splenomegaly, they're mild to normal. And only 3 patients, so 12% of them had moderate spleen volume between 5 to 15 multiples of norm. And none had severe enlargement of the spleen. I want you to see this funky number here. So the liver volume here, there seemed to be a preponderance of children with an increased moderate size of liver volume. So that's between 1.25 to 2.5 mN. And I think this is actually due to the fact that we're using ultrasound. I think it's an overestimation because the ultrasound is not a great way to calculate liver volume. And in fact, the one patient that is now a teenager and we were able to do the MRI, the time that he switched from the ultrasound to the MRI, we saw a drop in the calculated MN. So I think that's probably due to the ultrasound and the limitations we have with ultrasound, because this number doesn't correlate with all the numbers that you'll see, all the percents, okay? Okay, and then so let's look at height because we worry about height and we worry about bone, right? So the height percentile, though, I think what I see is going along a general population growth curve. So there'll be approximately 30% people within the 5 to 25th percentile. The majority of people are above 25th percentile. So I think that just goes along with the growth curve of the general population. But then if we look more closely, and let's compare now these children to their expected mid-parental height, what you see, the majority of children do match their mid-parental height expectations, but 7 children out of our cohort, or 19% of the children that we see, they're fallen just below what's expected for mid-parental height. 1 standard deviation is below expected. And so far, none of the children that we've seen had less than that, so below 2 standard deviations below expected. And then same thing in terms of changes in height or decrease in height percentile. Majority of children maintain their height percentile at that growth curve. And only 2 children that we had followed had a decline in their height percentile. So again, most children don't have issues with growth. The major thing we have to do is just comparing them to mid-parental height expectations, and that's really what we see here as a significant value. And then bone mineral density, we talk about Z-scores in children. So less than 2, less than -2 means osteoporosis in children. Between -1 to -2, that's a place where we said osteopenia, and above -1, we say this is normal. So we have only 2 children in our cohort with osteopenia, and the majority of children had normal bone density, and none had severe osteoporosis. Okay, so this is a slide in looking at Kaido, because you guys ask me about Kaido a lot. I was like, well, what does this mean? So Kaido, just to remind some of you, or for those who you don't know, chitotriosidase is an enzyme that lives in the macrophages, and then when the macrophages are stimulated and they're stressed out, they then release the chitotriosidase. The chitotriosidase doesn't do anything for us physiologically, so it's just a marker that we see. So, but it is a good measure or a marker or reflection of, you know, how stressed is that macrophage. And so, so while it's a marker for Gaucher disease, it can fluctuate also day to day and visit to visit, because it also depends on just what the macrophage is encountering at that visit. So you could see this wild fluctuation of chitotriosidase in our group of patients. But we can sort of make some sense of the trend. So each of these round dots is a patient and their chitotriosidase level at a particular visit. These are the ages at the visit, and this is their chitotriosidase. First, I want you guys to know is it's very minimally elevated, if at all, in the neonatal period. So we don't expect to see a large chitotriosidase level as soon as you're born. But it does sort of trend over time. As you know, if you look at the spread of the dots, we do see a trend of increase as we grow, I would imagine as the lysosome storage is getting larger and larger, and the macrophages are getting a little more stressed out. And so we also expect, and we do see sort of increase in chito as we age. Okay, and so what I wanted to do in this graph was to separate the children that we had not yet recommended to start enzyme replacement and the children actually that we had recommended to start enzyme replacement. And those children, there were only 4 of them, so 11% of our cohort. So in the red line, you'll see sort of the trend of the children, the 4 children that were recommended to start enzyme replacement at this time, at the last visit, and then the children who so far are not recommended to start enzyme replacement. And you could see actually there is a difference in the slope of the curve, right? You could see a difference in their trends. We had talked about how I like to use the Gaucher severity score, so I wanted to see how that plotted as well. So the GSS stands for Gaucher severity score, and then it sort of had a similar feel when we were looking at this plot, that the Gaucher severity score is increasing over the years as we're following these patients. And that the trend or the slope of the curve seemed to be higher in patients we had actually recommended to start enzyme replacement. Okay, and then this is also just for my curiosity, I had plotted chitotriosidase against Gaucher severity score to see if there was some correlation. So again, this seemed to suggest that there is a correlation between chitotriosidase level and the total Gaucher severity score that we see clinically in these patients. And this is a very busy slide, but it's a very interesting one. Each box is a patient. I was just trying to see visually whether we could see a difference in the trend of the Gaucher severity score. So each dot represents a Gaucher severity score of each of these patients at their visit. And there are two colors here. So the red dots are the children with the N370S homozygous genotype, and the blue dot are the children with the N370S R496H genotype. So you could see in general that I did this line across, that the hash line across is where the GSS score, the Gaucher severity score, is at 3. And you can see just visually stepping back, majority of these children had a GSS score below 3. So overall, the group is very mild. I put a little marker on the 4 kids who were recommended to start enzyme replacement. And you can see compared to the rest of the cohort, their GSS score does the trend a little bit higher, right? And then looking at the blue dots, so again, this is reminding you about the patients who are N370S R496. They're very mild, right? None of their dots have reached above GSS score or severity score of 3. So very mild condition that they have. Okay, so I know you guys were thinking, well, what about these 4 children that we had recommended to start, and why were they recommended to start? So I broke it down here for you guys. So patient number 17 started on enzyme replacement at age 7 because of persistent short stature that was below the expected mid-parental height. And had persistent mild to moderate thrombocytopenia, mild to moderate splenomegaly, and also osteopenia on DEXA scan. So through everything, all the stuff that was going on, we had recommended that this patient start. Patient 19 was recommended to start at age 14. Again, because of the stature was below mid-parental height and a decrease in height percentile at that time. So we have been following closely in these visits, and then there was a change in the height percentile, was decreasing. And then there was moderate hepatosplenomegaly. I have to tell you, the moderate hepatosplenomegaly was not terrible. What was really concerning for this family was age 14 is puberty, or the start of puberty, and this family really
in Gaucher. The prevailing opinion at the time was to advise all women to avoid pregnancy at all costs if you had Gaucher disease. This is in the 1940s and the 1950s. If a woman became pregnant, regardless of a prior successful pregnancy, the physician recommended termination. This is shocking. This is completely written in 1940s and 50s literature. But as they reported successful outcomes of women with Gaucher having successful pregnancies, the medical opinion started to change, and that was important to know. And obviously, from the 50s to the 90s, if you look at the literature, you see the complications still remain. So it was risky, but it was done. What were the risks? Worsening anemia, worsening platelets, leading to prenatal bleeding, but postnatal hemorrhage, requiring transfusions. The liver and spleen could enlarge during this time. They were worried then about encroaching on the growth of the fetus. But in worsening bone pain, osteonecrosis could occur during pregnancy. Pregnancy is a hypermetabolic state, requires a lot more energy, and if you're untreated, it's taxing the system. When they did a survey of 102 pregnancies in 53 patients, they showed up to 37% had first trimester bleeding, a spontaneous abortion rate of 25%, third trimester bleeding of 5%, and up to a third had worsening of their platelets. Their skeletal symptoms did worsen in about 24%. Postpartum courses showed significant amounts of hemorrhage. 70% of patients had some form of hemorrhage, requiring transfusions in 55%, post-op fever in 44%. With the advent of enzyme therapy, that changed dramatically. And another series showed in a cohort of pregnancies, about 60 pregnancies in 40 women, absolutely no complications of hemorrhage or requiring transfusions. So ERT has been associated with reduced risk of spontaneous abortions in females with Gaucher, reduced risk of GD-related complications. Organomegaly was stabilized or did not worsen. Bone pain, bone crises were reduced significantly. And women were able to come through the delivery intact and with good outcomes. The fetuses were not affected. So we worry about using medications during pregnancy, and that's a question I get quite a bit from my women who are thinking about having children. And if we look at the literature since the advent of ERT, we see increasing reports of good outcomes with the babies, no adverse effects on the infants. The rates of spontaneous abortion, miscarriage, or genetic anomalies are relatively the same between untreated and treated. In the paper that we did, we looked at, just quickly give you a sense, of 453 pregnancies and 189 patients. 117 of these pregnancies were exposed to therapy in those 68 patients, as opposed to 336 pregnancies in untreated. So that was probably before ERT. And out of those, we look at the outcomes were essentially the same. And I'm going to be a little bit more brief, and you can ask me later about the specifics of it. But what we showed was that ERT, preconception through the entire pregnancy, had good outcomes for mother and baby, and there was no suggestion of any adverse effects of the enzyme on the child. This is not a uniform blanket recommendation. You need to talk to your doctor. If you're not on ERT, simply becoming pregnant is not a reason to start ERT. You have to sit down and look at your disease burden and the reasons why you were not on ERT beforehand. Unfortunately, recently, one of my patients who was new to me, she did not want to be on therapy, and she got pregnant. Her platelets are below 70,000. She has overwhelming splenomegaly, and so we have to kind of catch up now for the rest of the pregnancy. But if beforehand your disease burden is low and you're not on ERT, simply getting pregnant does not reflexively put you on the ERT. But if you're on ERT or you're not on ERT and you start to have worsening of your Gaucher symptoms, then that might be an indication. So I have a couple of slides to show that. So management of Gaucher disease in pregnancy should start preconception. Sit with your doctor. What is your health status? What is your disease burden? Should you be on therapy or not? If you're kind of borderline and you're thinking about it, you might opt for ERT beforehand, because there's always a risk with ERT, with hypersensitivity reactions occurring. And then while you're pregnant, to have surveillance. Finally, the multidisciplinary approach applies here as well. I work with a hematologist, I work with anesthesia, I work with orthopedics if needed, as well as the OBGYN. Certain hip issues from the prior ages of avascular necrosis can impact vaginal deliveries, so that's important to consider. Most of my patients can withstand a vaginal delivery and do not need C-sections, but some who have had avascular necrosis of the hips needs to be seen by orthopedics to be cleared. Hematology. Well, why should they see a hematologist? They've been diagnosed with Gaucher already. Well, to make sure that there's no platelet dysfunction as on top of platelet levels, make sure there's no other coagulation or clotting problems. Somebody had asked me beforehand, recurrent abortions or recurrent terminations, are they part of Gaucher? In the pretreatment era that happened, and sometimes it was due to low platelets and other times it was due to a comorbid clotting problem that is also prevalent in certain ethnic backgrounds. Okay, so I'm going to summarize here. Gaucher disease is a multisystemic disorder that affects patients over their entire lifespan. And women in particular have specific parts of their life that are affected by Gaucher, including menarche and pregnancy and their bone health. Pediatric patients have additional issues with growth and puberty, and therefore the assessment of whether to start ERT has to take into those accounts, into that account as well. For adult women with Gaucher, especially post-menopause, maintenance of bone health is important and to reduce the risk of fracture. and it may include anti-osteoporotic medications. And finally, for women who are of their childbearing ages, it's important to sit down, define your disease burden, decide about therapy, and then receive some comfort from the fact that ERT has been used throughout pregnancy. And one final word, SRT has not been looked at in pregnancy. And I did have a slide on showing that substrate reduction inhibitors, Serdelga and the others, they are small molecules and potentially could cross the placenta. So I would caution against the use of SRTs in pregnancy. Thank you.
Okay, that deserves an extra round of applause. While Dr. Lau was presenting, they have been working on the tech component here. Are we good for Dr. Yang's presentation? We're good. Okay. Dr. Lau, thank you so very much for all that winging. And this goes to show that technology has its ups and downs. So thank you.
All right, thanks for for your patience. Okay, so my talk today is going to be about pre-symptomatic children that we've been following at Mount Sinai. I started this whole thing in 2012 under Manisha Bhawani's guidance at Mount Sinai. So it's only been a few years, but it's a great learning few years. And I think one of the most amazing thing is just the wonderful team that we have, but also at Mount Sinai, there's a very interesting phenomenon where we take care of patients with Gaucher, but we also do carrier screening up at the lab. And I think through many efforts within the community, including National Gaucher Foundation and other Jewish genetic screening programs, we've been able to, over the years, pick up carrier couples. And then I've been fortunate enough to see some of these carrier couples prenatally during the fact that they were diagnosed as couples. They want to know more about Gaucher disease and how that would affect their child. And then so we've been able to follow these children very early on. And I think, so I'll be presenting some of that data today. Sorry. I don't think this is working. Yeah. He's going to make my controller work. Okay. Oh, wonderful. Okay, great. So first, very quickly, I'm just going to review what clinical guidance we do have out in the literature about following children with type 1 Gaucher disease very quickly. And then I want to address the questions that we hear over and over again with families and carrier couples that pose these questions to us. And this is really, these frequently asked questions were the reason for the study and the data that I'm about to present. So I will present that data from the children that we've been able to follow at Mount Sinai. Okay. And in particular of note, I just want to say that, and I'll show you the breakdown of these children and their genotypes, but the majority of signs and symptoms I'll be describing is mainly from patients who have genotype N370S homozygous. So that's very important to remember, that this is a very particular genotype or group of patients with this genotype, and I wouldn't be able to give you any data on the genotypes are N370S with other mutations are more severe. We just don't have that data, unfortunately. Okay, so this is written in 2013, about the time when I started with the lysosomal storage disease program, so I was very happy to have that. And it was led by a group of pediatric Gaucher disease experts, including Dr. Kaplan. So basically, the recommendation for symptomatic children, so these are children who present with their Gaucher disease to the doctor. And so, of course, they're going to be started on enzyme replacement, because some of you may know from the community and the experiences, these children could have quite a number of disease symptoms, including large spleen, low platelets, anemia, and all the things that Dr. Lau had talked about. So of course they're going to be on enzyme replacement. So while these children are on an enzyme replacement, the recommendation is, as Dr. Lau had presented, every 6 to 12 months they'll be followed for non-skeletal assessments, and that includes a physical exam, including a good neurological exam, and follow.
That then, after age 30, is going to slowly decrease. So in a study, actually the paper was led by Dr. Mystery, the impact of Gaucher disease in children. In pre-treated children, low bone density was prevalent in all age groups. If you stratify, 44% of children demonstrated some sort of reduced bone density when compared to other children. 76% of adolescents had reduced bone density, 54% of young adults, and 52% of older adults. And this is obviously, with the adolescents, probably related to the other growth spurt and the pubertal delay that we're seeing. And so that is a critical time period to intervene if you need to do so. So how do we optimize bone health in children and adolescents? So what we worry about is making sure that before, regardless of treatment or with enzyme or not, we need to have adequate calcium intake and vitamin D. Those are the building bones of bone. So my patients ask me how much and what should I be taking, and we can talk about it after, but in general, 50% of the total body calcium is laid down in puberty for girls. So you want to make sure your children are getting good calcium intake. Calcium is interesting. You can't take all of it in one sitting, is how when I talk about it in my clinic. You have to divide it throughout the day. And the best source is actually from your food. So calcium from yogurt, dairy is better than taking the supplements. The vitamin D is a little bit more difficult to get from dietary sources, and we certainly don't recommend to go out into the sun anymore. But vitamin D can be, you can get it from salmon, you can get it from other, from fortified foods. Okay, sorry. But it's important to make sure it's adequately supplemented. And there are actual drops that you can take, vitamin D3, to increase the levels. The total levels for children between age 9 and 18 are 1,300 milligrams per day. The other aspect is making sure your children are active. Exercise is probably the most important component of building bone in adolescence. In a prospective study back in the 90s, it followed 264 patients, not with Gaucher disease, aged 9 to 18, and they found that over those 11 years, those with the best bone were the ones that had maintenance of normal weight, exercise, and non-smoking. They remained without smoking. So those are easier ways. And then the question is, what about ERT? Well, ERT in many studies have shown some kind of correction of this growth delay. And we do have a graph, again, from the paper in 2011 by Dr. Mystery, showing that there is an increase in bone density from one range to another. Sorry. However, it does highlight that peak window of opportunity to intervene is before or right before puberty, because that's where you're going to start laying down the most bone. So what about bone health in adults and females specifically? As I said, bone is remodeling all the time, even in adulthood, both forming and resorbing. The peak bone mass that's attained by 30 starts to decline, and it more rapidly declines in women after menopause. And that's because the two most important factors for the development of osteoporosis is being a female and age and loss of estrogen. A clinical diagnosis of osteoporosis, I'm sure most of you are undergoing some kind of surveillance with DEXA scans, and your doctor is looking at your T-scores and making sure that they stay within normal or at least stabilized. So reduced bone density comes in either osteopenia, which is a -1 to -2.5, then osteoporosis is more severe. And what's the difference? The risk of fracture is substantially larger when you hit the osteoporotic range, and that's a T-score of more than 2.5, -2.5. The best way to do surveillance is through DEXA scans, and the timing of that is very important. It's hard in some of our patients to justify, so most women without Gaucher disease start to do that postmenopausal surveillance. However, we need to look earlier. And over the past 10 years, we see that we're doing it now in adolescents and even in children, and we're developing standards to compare the bone density. So if we look at the Gaucher disease population specifically, the estimated risk of osteoporosis without treatment in one study showed anywhere from 10 to 30% in women and 10 to 25% in men. So again, the Gaucher, the enzyme deficiency state leads to a worse or increased risk of developing osteoporosis. So how do we manage bone density in adults with Gaucher disease? Again, it's calcium, vitamin D, and exercise. The calcium requirements are slightly different depending on your age. Total 1,000 in premenopausal women, and then 1,200 in postmenopausal women. We want to avoid overdose, and we still need to divide those doses into 2 to 3 servings or supplements throughout the day. Vitamin D, again, the source from the sun is not the best for us, but we can get it from our diet and fortified foods or simple supplement. You can follow the levels, and that's what I do with my patients, so not one type of dose is correct. And typically, I'll do a level, and then we'll try either 800 or 1,000 units a day, and then go from there and see if we can get that target level between 40 and 60. I work hand in hand with our rheumatologists and endocrinologists, because in the osteopenic range, or the mildly low bone density range, what we're doing now is just modifying our lifestyle factors. So also encouraging weight-bearing exercise. A common question I get is, what is weight-bearing exercise? So walking is a great exercise. Running is it has a bit of an impact on the joints and may not be for everyone. But things like swimming, although good for your cardiovascular health, is not as weight-bearing. And then weight resistance training. Anything that tugs on the bone is going to build the bone and stimulate remodeling. Diet, there's no clear evidence to have a high protein or low protein diet, so that's not really a tactic, just getting the fortified foods that you need. And then smoking cessation. The best thing you could do for your health is what I tell my patients. Yes, we're correcting your enzyme, but you're still smoking. And I actually have that in quite a few patients. And that is probably the number one thing you can do to help to give you a better outcome. And obviously avoid excess alcohol and caffeine, because that can also affect your bone density. I had some examples of food for both vitamin D and calcium, because that's asked a lot in my clinic. So what about Gaucher-specific therapy? For children, I did show in a couple of slides that there was improvement. And there is data now showing that bone, although it takes longer, can respond to enzyme therapy over time. And then also the SRT, new abstracts are coming out from the long-term data from Sir Delga, showing an improvement in bone density. I have a poster, an oral presentation later this month, to show that the 8 years on elaglustat showed that there was improvement from osteopenia to the normal range in the lumbar spine. And Dr. Mistry is also presenting long-term results of elaglustat of a separate study, again showing improvement just on 4.5 years in the spine T-score. So it is affecting bone, and that's wonderful news. So management of osteoporosis. So if you migrated now from osteopenia to osteoporosis, that's when I bring in my rheumatologist and endocrinologist. This is a multisystemic disease that requires a multidisciplinary approach at all phases of your life. So here I send them off to the rheumatologist and endocrinologist because they know their therapies. And we're going to start looking at different classes of therapies. Now, we don't have one good study to say this is the type of drug we should use in Gaucher disease-related osteoporosis. That should be done, and that would be a good study to do. We have the bisphosphonates that I'm sure most of you are aware of. Fosamax is one of them, Actonel, Boniva, those are the brand names. There's different approaches. So the bisphosphonates help to reduce bone resorption, but then there's parathyroid hormone derivatives that mimic the endogenous hormone to promote bone formation and remodeling. It's a daily injection for a short period of time, for about 24 months. And then there's Prolia, which is actually an antibody that attacks one of these rank ligand molecules to improve the formation. Now, each of these diseases, therapies, I'm not going to go into what is better than the other because it really depends on the individual before me. It depends if you have esophageal issues and you can't tolerate the reflux. It depends on risk of cancer. There is a black box warning on one of them. But it has been reported to be used in patients with Gaucher disease. So we don't know which one is best, and you should sit down with your endocrinologist and go through it. And your endocrinologist should call your Gaucher doctor. We used to have patients sit on Fosamax or one of the bisphosphonates for years, and there's an increased risk of jaw necrosis. There are risk factors. So you have to weigh the risk versus the benefit of being on therapy and of what type of therapy. Because what we're trying to ultimately reduce is the risk of hip fracture or silent pathologic fractures of the spine that can cause significant pain and decreased quality of life in your 50s, 60s, 70s, on top of any other joint problems that you might have. I have one patient of mine. She is dear to me. She sees me every 3 months, more for social support, I think. She is absolutely afraid of taking any of these therapies, and I've slowly increased her enzyme therapy up to a more therapeutic dose for her. And despite not taking her vitamin D and not taking any of these other potential anti-osteoporotic therapies, she's increased her bone by 20%. So that'll be reported on next year. I don't advise that, but that's very interesting that her enzyme alone helped to build her bone. That's an N of 1, and I'm going to start looking at my other patients. But at the end of the day, it's a multimodal approach. You have to maximize your vitamin D, your calcium, and you have to look at your enzyme therapy or your SRT. Okay? All right, so the final few minutes, if you can allow me, I do want to focus a little bit on pregnancy. This past year, I published a paper on pregnancy outcomes in collaboration with a registry. And that's because it's near and dear to my heart. My patients that go through their pregnancy, it's such a, like I said before, a wonderful time, but it's also sometimes scary for them. So the typical pregnancy, the typical physiologic changes during pregnancy for any woman includes mild anemia in your second trimester, necessitating iron. You can have a transient decrease in your platelets in your third trimester, up to 5% of patients that spontaneously resolves later. You can have ligamentous laxity, so you're a little bit more double jointed or prone to some injuries, low back pain, hip pain, which can mimic or get confused with Gaucher pain. In the postpartum, up to 6 to 8 weeks it takes to reverse some of these changes. So now you add in Gaucher disease. So pregnancy definitely has the potential to exacerbate all of the Gaucher complications. When I looked back over the literature, the first reports of pregnancy, but there's this increased risk of multiple myeloma that's on the radar of every Gaucher expert, and we screen for it after age 50. It's higher, much higher than the general population looking at different studies. But again, like Dr. Grabowski said, overall, most people don't develop either Parkinson's or multiple myeloma. But if you've developed it, it's affecting you, and we need to understand that connection better. And there's also increased risk, as we're seeing, of immunologic abnormalities. In the front lines, as we're seeing our patients, we're seeing autoimmune disease. I'm seeing autoimmune diseases. I'm seeing autoimmune ITP. I'm seeing monoclonal gammopathy. I'm seeing all of this. And now we're going back to the lab and understanding it better. Okay? All right, so medicine these days, personalized medicine is a hot topic, but it really is relevant to Gaucher disease because of the heterogeneous nature. Even within families, your disease burden is different than your sibling or your parent. So you have to work with your Gaucher provider to clearly define the disease burden, where it affects you, and then together, your goals of treatment, which differ based on age, sex, comorbid conditions. Are you diabetic? Do you have high blood pressure? Do you have autoimmune conditions? And then looking at the disease burden, defining it in the baseline or in your initial meeting with your doctor, the hematologic manifestations. Not everybody has anemia. That is not a problem for many of my patients, but the low platelets puts them at risk of bleeding or for post-surgical bleeding, prolonged bleeding after the fact. Bone may or may not correlate with other symptoms. Again, as I said before, some of my patients don't have visceral symptoms or hematologic, but they do have bone. And then in the pediatric population, the question of growth delay and pubertal delay, and whether that is corrected or ameliorated by enzyme. We'll talk about it a little bit. So for women specifically, Gaucher can affect menarche. It has a significant role in pregnancy and in menopause and bone health. Okay? So what are our general treatment goals for our patients? Of course, when you're initially coming in and starting on therapy, I had several patients come in the past month who have never been on treatment. And we have to sit there and manage their expectations. Enzyme or substrate reduction inhibitor are very effective treatments in certain aspects. So we want to obviously correct the anemia and the platelets, and that can take as long as 1 to 2 years, and some of my patients are actually refractory to normalizing completely. But you can see changes as early as 3 to 6 months, and what's most important is the post-surgical, obstetrical, and spontaneous bleeding risks are reduced. Obviously, reducing the liver and the spleen, those are organs that can reduce in size. There are some limitations if you have prolonged disease leading to fibrosis or scarring of the organ, but still you can see some dramatic response within the first year of therapy and over the next 2 to 5 years. Obviously, most of my patients are now not splenectomized. Unfortunately, one woman had a very rare complication due to mild splenomegaly after childbirth, leading to torsion, and she lost her spleen. But that's pretty rare, both described by myself and Dr. Zimran in Israel. But in general, most of our patients are able to retain their spleen now. Improve bone pain. This can take time. The bone pain, which could be reversible without evidence of permanent damage, can still take 1 to 2 years to improve. So the aches and pains that are still remain after starting therapy is still burdensome. And of course, we want to prevent future damage, irreversible damage, including avascular necrosis. And finally, what's more on our minds are the asymptomatic aspects of bone health. Bone density. We don't feel our bones. We don't feel how thick they are, but they are affected. And possibly because in the pediatric range, we're not laying down enough bone. And I'll talk a little bit more about that later. Then obviously in adulthood, we start to lose bone density with age, and there are certain risk factors that increase that likelihood that you could progress from osteopenia to osteoporosis, ultimately leading to an increase in fracture. So how do we manage that with our patients with Gaucher? And obviously subjective, improving fatigue. That fatigue can be from the anemia, or there's an independent, just overall fatigue related to Gaucher disease. And that I do find from my patients who were off drug during the shortage several years ago, their first thing that they felt was the fatigue return before their anemia and platelets in several of my patients. So what is the treatment for Gaucher? We all know enzyme replacement therapy, with the first being back in 1991. And I'll go through briefly in the other three, the three current enzyme therapies. And it is possible to reverse many of the signs and symptoms of the disease, but it's not completely correcting everything, as we saw earlier. And now, there was one substrate reduction inhibitor that's been around for several years, but the new one that's out, called Serdelga, works in the same way. We're basically reducing the accumulation of GC in the cells and then letting your own enzyme clear out the cells. And the pivotal trials do really show quite an effective response, even if you've never been on enzyme before, to be able to normalize your anemia, your platelets, and your liver and spleen, and even your bone. Okay? So here we go, just in a brief summary slide that you can take a moment to look at. My patients always ask me, what are the differences in the enzymes? So I do go into detail with my patients about the three current available enzyme therapies. I get lots of questions, which one's better, which one works better, and I sit there and I go through the data with all of them. They're all proven to be effective at reversing many of the symptoms. They are made slightly different, but at the end of the day, the choice is discussed between me and the patient and their particular questions and concerns. So we have imaglucerase, Cerezyme, velaglucerase, Vpriv, and talaglucerase, a little bit newer, Elelyso, which is marketed by Pfizer. So 3 different companies, 3 different enzymes, and a whole lot of literature out there to go through with my patients. Now, enzyme replacement therapy requires intravenous infusions every 2 weeks, a range of doses you can talk about with your provider, depending on your particular disease severity. And then there's the substrate reduction inhibitor. Miglustat is the oldest. It's also known as Zavesca, been around since 2003. It's a second line if you fail the other ERTs. It does not have first line indication. And then elaglustat or Serdelga, recent approvals by Genzyme and Sanofi, and that's a first line. For patients naive to treatment, they can start on Serdelga. There are all risks and side effect profiles related to each of these therapies, and I would implore you to talk to your provider about what works best for you. Obviously, this is oral and this is intravenous, but there are other reasons why you might choose one over the other. Oops. Ooh. That's not that finished. I have about 40 other slides. I'm not sure if someone can help me. I have it on my phone if I need to forward it somewhere. Okay. I have it memorized, I can do that. Probably be easier for me too.
If we get a logo for a moment, Gary.
Okay. So the next part of the talk was going to talk about impact of Gaucher disease on pediatric patients, and then a little bit of a focus on girls in particular. So there is a question of when you present in childhood, we do see short stature in some of our patients, suggesting that there is some kind of growth problem or delay. When I've sent my patients for evaluation just to ensure that there's no other factor going on, it comes back to that it's probably the Gaucher. So when we look at a child who has short stature, we look at their parents, and we want to calculate their mid-parental height, and then see where they fall in the curve. So even if your child is 5th percentile, if your parents are 5th percentile, it's not so much of a discordant there, and we think that's their genetic potential. But if your parents are 5'8" and 6'4", and your child's 5th percentile, you wonder then, is there something impacting that? And Gaucher disease has been reported in many studies to show that there is some growth delay. In some series, especially one in Israel by Dr. Zimran, showed that Some percent, up to 40%, eventually normalize their growth even without treatment. But then there's another cohort of children with Gaucher that don't normalize their height. And so that's a question about indicating for treatment possibly. So the growth delay goes hand in hand with pubertal delay. And so for females that are not treated, during puberty you can see some delay in menarche, which is also known as menses, onset of your menstrual cycle. So with enzyme replacement therapy, there are certain studies that have showed normalization of growth and puberty. But in addition to having untreated Gaucher children, during menses you could have menorrhagia, which is prolonged bleeding, as well as the delay in the menarche. So that's another, it's not a sole indication for treatment, but we have seen in a series in Israel where there was a significant proportion of bleeding. Oh, thank you. Oh, so I did send it, didn't I? Okay. So the treatment guidelines for children reflect the adults. We want to correct anemia, correct platelets. We want to reduce the liver and spleen down to sizes that are not dangerous, and as well as make sure that we correct any growth delay. Okay. So I quoted here from one of the studies by Dr. Kaplan back in 2013. ERT has reduced the incidence of severe and irreversible initial complications in pediatric patients, and this has permitted better development of these patients. So the silent disease, the bone disease, that's what we want to prevent. So there's two forms that I worry about, development of avascular necrosis, which is irreversible bone damage, because that weakens the bone and sets up a child later in life for possible issues with needing joint replacements and such, but also bone density. So from pre-adolescence to the end of the second decade, bone size and bone mass increase rapidly. The greatest deposition of bone mineral occurs between age 8 and age 18, most depositing during puberty. So this is normal bone development in a child that does not have Gaucher disease. The bone width increases before the mineral content, and it increases before the bone density. This occurs much earlier in girls, 12 months before menarche and up to 12 months after. So that's where that greatest change in bone mass and size occurs. And as it's occurring, there is actually a little dip in density, and there's an increased risk of distal radius fracture in children at that time point. This is in non-Gaucher children. Peak bone mass is achieved by age 30. So I have a little graph here to show that. But again, bone mass bone is a dynamic organ, just like your liver and spleen. It's just much slower to change over time. Bone remodeling is a balance between two different types of cells in a very basic sense, the builders and the destruction. So the osteoblasts and the osteoclasts. And that is what happens in adolescence. That is a critical time period to build bone.
We're good. Excellent. Is the panel, are we going to have like a panel discussion about it?
Yeah, at the end. Around 2:15.
Okay, that's the
Dr.
panel.
Mystery,
Yes, yep.
who is the second gentleman
Yep,
in,
yep.
will moderate a Q&A for the rest of the panel. That's up to you.
Great. Okay, because I'm going to keep their lights off
That's fine.
until they're really
Totally
ready to go.
fine.
Okay.
And that way also we'll be able to, I'm going to sit on the end because I'm going to see if there are questions that are coming in from live stream that I'll be able to.
Ask you about that too.
Yeah.
Okay, good.
Okay, wonderful.
We have a backup mic here, just in case.
Okay.
And I'm just saying.
Okay.
You know.
Hopefully this is
You
fine.
know.
So are we good with this?
If they started a really good conversation back and forth,
Okay.
and one wants to dominate or take over or
Okay.
whatever, feel free to.
Okay.
Just so we can get a good feed.
Great.
Line. Yeah.
Great, great. Ladies and gentlemen, I hope you're enjoying your meal. We're certainly enjoying having you here. So one of the things that we have done today, for those of you who were able to join us in person, we had a computerized drawing of the names for people who are here because we have some prizes. And when I call your name, just know that before you leave today, please see Sarah Sickerman, who is on our marketing team, and she's been outside at our registration table all day, and you'll be able to collect your prize. Okay, so Howard Adelson, congratulations. You've got a pair of Bose Sports headphones. Bob Krupskas, where's Bob? I think I saw him. You got an Amazon gift card. Okay. Okay, Valerie Mario Stein. I hope if I'm mispronouncing your names, please forgive me. So Valerie, are you still here? Okay, well, please see Sarah because you have won an iPad. Okay. Ginger Nathanson. Ginger, you also have won an iPad. Congratulations. Okay. Howie Neighborg, also an iPad. Okay. Suzanne Posner, you've won a Fitbit. Okay. Because we're all about living a better today. Okay. Rebecca Weisberg has also won a pair of Bose headphones. Annette Brindell. Annette, hi. You also have won an Amazon gift card, so please see Sarah before you leave today. Teresa Cottons. Teresa, you won a Fitbit. And one more, Asa Abelovich. Asa, are you still here? He's here somewhere, I think. Also a pair of headphones. So please do see Sarah before you leave today, and thank you so much. Okay. So one more quick announcement before I introduce two of our other wonderful speakers today. Lindsay Zuckerman, can I ask you to stand, sweetie? Hi. Okay, so Lindsay and one of your girlfriends, Alyssa, or is Alyssa the mom? Allie, I'm so sorry. Lindsay and Allie are two very fine young women who happen to have Gaucher and are committed to raising awareness about the disease. In fact, Lindsay took on a magnificent endeavor in January of 2016 in preparation before her bat mitzvah to do such a thing. And she, with the help of her mom, created an incredible dance-a-thon that was incredibly well attended and supported, and they raised over $16,000 for the National Gaucher Foundation. So this year, Lindsay and Allie looked at each other, and they wanted to do something during Gaucher Awareness Month. So tomorrow, there are flyers out on one of the tables. Tomorrow, they have coordinated with a local restaurant in the New Jersey area, California Pizzeria, that anyone that is interested in going in and having a meal tomorrow and takes in one of those flyers, the restaurant will donate back a percentage of the meal back to the National Gaucher Foundation. So it's a way for them to raise awareness and to raise funds for the foundation. And I thank you so much, Lindsay, and Allie, who's not here, but her mom, Alyssa, is here today. Okay? Thank you. Okay, I'm going to introduce two of our next speakers. And then I'm going to allow them to do their presentations back to back without interruption, okay? One of our next presenters is Dr. Heather Lau. She's a board-certified neurologist with special qualifications in child neurology. She has subsequent fellowship training in neurogenetics. Her practice focuses on diagnosis and management of adult and pediatric patients with suspected genetic inherited neurodegenerative diseases, with an emphasis on lysosomal storage disorders, leukodystrophies, and genetic epilepsy syndromes. She also serves as a principal investigator on multiple clinical trials evaluating the safety and efficacy of therapies for a variety of rare neurogenetic disorders. Dr. Amy Yang will then present afterwards. Dr. Amy Yang is the Associate Director for Lysosomal Storage Diseases Program and a clinical geneticist and assistant professor in the Department of Genetics and Genomic Sciences at the Icahn School of Medicine at Mount Sinai. She received her medical doctorate from NYU School of Medicine in 2006. She completed her pediatrics and medical genetics training at Mount Sinai and is board certified in both. At Mount Sinai, she directs the medical care of children with Gaucher disease, as well as adults and children with other lysosomal storage disorders, such as Fabry, Pompe, MPS, and Batten disease. So please give your attention to Dr. Lau and then to Dr. Amy Yang.
Good afternoon. Thank you so much for inviting me to be here today, to the NGF and to Amy. Several months ago, Amy approached me to ask me to speak on a topic, and I gave some thought to it. And I decided, knowing that actually Dr. Grabowski's topics, this topic stemmed from what I see in my clinic every day, week by week. I'm the director of the lysosomal program at NYU, and with a very large proportion with Gaucher type 1. And so when I sit with my patients, the questions that come up kind of direct how I do my research and my education. So So today we're going to talk about management of Gaucher across the lifespan with a focus on women. However, it will be relevant to all of you in the room. So I'll spend a little bit of time on pediatrics and then talk about some adult-related issues. Here are my disclosures. As was stated in my intro, I do research, and a lot of the contracted research is with pharmaceutical companies who are developing novel approaches to treating lysosomal storage disorders for Fabry, Pompe, and Gaucher, as well as other ones to be determined in the future. I also serve on the advisory boards for certain other diseases, including the Tay-Sachsen-allied diseases, as well as adult polyglucosin, another Jewish genetic disease. So today, just briefly, because we're going to go back to basics, we had some wonderful illustrations and of the pathophysiology of the disorder, but we'll just summarize that briefly and go a little bit into the treatment options. What I want to focus on is the treatment or the management of the whole person and not just the disease. And we're going to look at it from age, looking a little bit in childhood here, and then go into on bone health in women. And then we're going to end with a focus on pregnancy, because that's been on the minds of my patients as I guide them through their pregnancy. Some of them are on their 6th pregnancy, and others are on their 1st pregnancy. And it's a wonderful time for them, but it's also scary to have a rare disease. And so we work very closely with their OBGYN to educate their care team to make sure they get the best care throughout their pregnancy. So as we know that Gaucher is an autosomal recessive disorder with a 25% chance of being affected if your parents are carriers. It's due to the gene, GBA, encodes a protein that is an enzyme, a lysosomal enzyme, that breaks down glucocerebrosidase into its components. When you're deficient, it accumulates throughout the body, causing the transformation of macrophages into Gaucher cells. It's pan-ethnic, but there is a high prevalence in the Ashkenazi Jewish population, specifically the N370S allele. And the symptoms of GD1 is heterogeneous, as we see, not only in age of onset, but also with severity and disease burden over time. So again, just a summary slide of how Gaucher affects the entire body. And we can look at here, it affects the liver and the spleen, enlarging those organs. And then it leads to bone marrow failure, where you have possible development of anemia or low platelets. Low platelets leads to a risk of bleeding and other complications. The spleen does enlarge, and then it has a vicious cycle where it traps further platelets and lowering the platelets even more. And then the bone complications, which can occur either altogether or independently. There are people that have visceral and hematologic abnormalities with relatively low bone involvement. And then there's the other patient that has normal platelets, no anemia, and no organomegaly, and bone or silent bone complications. There are certain aspects of the bone complications that are reversible, bone pain, but there are other end stages that are irreversible called osteonecrosis, and then of course affecting the thickness called bone density, leading to osteoporosis and an increased risk of fracture in later life. Okay? But here are some other multisystemic effects that are still surprising to some of my patients. When the patient comes into my office and they said, well, or they're new to me, because we try to go through everything in our first meeting, and they said, well, I said, do you ever get a little upset stomach after a fatty meal? Do you ever have a gallbladder attack? Yes, I do. So gallstones is connected to Gaucher. But in the pretreatment state, there is a hypermetabolic state. And in a small percent of patients, and we're seeing this decrease over time, and we think it's related to the spleen, but there are still some patients that develop pulmonary infiltration or pulmonary hypertension. Rare, but it still happens, and we screen for it. As we all know, there's the hot topic of increased risk of Parkinson's disease. We're not going to focus that on today. We've done that in the past.
If you might be willing to recontact us to discuss whether you'd be willing to have us continue to use your samples in the future. And again, if any of you would like to come back to the NIH and be seen, we'd also be happy to evaluate you. And thank you for participating in ongoing research and for all you do for the Gaucher community. Thanks.
in a programmed manner. And this is all regulated through the lysosomal function. So this is the beginning. It looks like, in many parts of Gaucher disease, this part called necroptosis is active. But it becomes more complicated, and this is the piece that's brand new and becomes important. There's a little molecule here called C5a. This is a component of the immune system that says there's danger there. We have to fight this off. And it ties into this system here that I just showed you. And this becomes self-propagating. This C5a is complement 5. It attaches to a receptor. It changes the nature of what's going on in cells, enhances all of these activities, and engages the entire immune system in saying, there's something wrong with this body, and we have to get rid of it. And that getting rid of it are the Gaucher cells. So it's this axis that controls glucoceramide, the essential lipid that's involved in Gaucher disease, its accumulation and tissue inflammation in Gaucher disease. So I'm going to talk to you about mice. And like I said, we're going to talk about mice because we can do things in them that we can't do in humans. And we have some models that are sort of like Gaucher disease in humans, but not exactly. And so we have this particular mouse here who has mutations in the Gaucher gene. It's got Gaucher cells and has all kinds of abnormalities in the tissues related to the immune system, and these red things keep coming out of the cells called cytokines. This is potentially the most important slide. We are able to take a particular molecule that will kill the Gaucher enzyme in all cells of the body. It's called CBE, condiryl B epoxide, made by a friend of mine, Gunther Legler, in the 70s. Very powerful agent, kills glucocerebrosidase, the enzyme in Gaucher disease, in all cells of a body. And we can do this in a timed way. So we can take wild-type mice, give them this stuff, and see what happens. And what happens is, this shows the survival over time, and these are days. We inject this stuff on a daily basis, we give it, and the mice die, and by 30 days, they're all dead. What do they die of? They die of certain kinds of visceral but neurologic disease. So these are Gaucher mice created with this inhibitor. We can also do this in some mice that have genetic abnormalities with Gaucher. Then we can get rid of this compound that I said was the receptor for C5a, and look what happens. They live. Okay. They live. And they live till we stop the experiment. That's amazing. Now, why would they possibly do that? Why would this molecule here that's involved with complement, which is way down the pathway from the inciting event in Gaucher, actually live? What causes that? And there are a whole bunch of abnormalities here that we can show that go away when we treat and get rid of this receptor. All these abnormalities are part of Gaucher disease. But the most amazing part was here. This shows the lipid, glucoceramide, that accumulates in Gaucher disease. When you get rid of this receptor, this goes away. That's not enzyme therapy. This is a totally different pathway. How could this be? And what we found was the following. In either wild-type mice, where we get rid of this receptor pharmacologically, or in Gaucher-like mice, where we get rid of this receptor pharmacologically, the enzyme that makes the lipid involved in in Gaucher disease goes away. It's diminished. The complement system is regulating the production of glucoceramide. So this is totally different than enzyme therapy. and these mice live. So what we have here is a downregulation of this enzyme that makes glucoceramide, the offending enzyme initially, or offending lipid initially. And then whatever enzymes left can work on whatever comes through, and you decrease the disease. And if you measure the amount of glucoceramide in these mice, in their tissues, it's near normal. So this is totally and completely a different pathway. So, surprising finding. And it gets a little more complicated. And this is where we need still to do a lot of work, and how this may have impact as we move forward in different kinds of therapies in Gaucher disease. So this is all part of a paper that was published in February. And what this shows is the initial event is your Gaucher cell. You're missing an enzyme or a lot of it, and you accumulate glucoceramide. And then something quite amazing happens. So in addition to this C5a that we talked about, your body sees this lipid, glucoceramide, as foreign. And it says, I'm going to make an antibody to this and get rid of it. So this becomes an autoimmune disease. And it's to the Gaucher lipid. And that antibody then does several things. It's complexed with glucoceramide, and only glucoceramide. It attaches to certain kinds of macrophages and enhances their activity. It increases glucoceramide activity. It also gets out into the bloodstream, enhances the production of this complement, which then can circle back into the cell, and you create this vicious cycle of enhancement of activity, increased production of glucoceramide, and the propagation of Gaucher disease. And it makes it worse. So this is why we move from the initiating event here to a far more complicated system of understanding how Gaucher disease actually causes the propagation of the illness and leads to ongoing damage. From these events, we don't know how these are connected yet to some of the fibrosis that occurs or in tissues, to some of the abnormalities in bone that occur, but this is a lead-in to how we could start to understand this. And to understand how this complement system, and the receptor in particular, regulates glucoceramide becomes incredibly important in understanding this at a biological level. So, the next question is, what do you care? Why would it matter to you? Well, because this is an important axis in the development of glucoceramide and metabolism, that's important. It modulates glucoceramide synthase, which is the enzyme that is attacked with these drugs called substrate reduction drugs. It tips the balance in glucoceramide metabolism, and therefore Gaucher disease, and controls the bad accumulation of this in Gaucher. This is a controlling event. We can target this axis with a drug, and it abolishes glucoceramide without any other therapy in mice. And it gets rid of the autoinflammatory parts of this. So it decreases the inflammation, all those red dots flying all over, and glucoceramide itself. The question is this a target for an additive, or alternative, or additional therapy to block the inflammatory responses in Gaucher disease in certain patients or in certain indications? And is this associated with malignancies and Parkinson's disease? The graph I showed you where the mice lived when we got rid of this receptor, that's due to the fact they don't develop any brain disease. So there's a big piece of this to be understood as we move forward. And I would point out again that most Gaucher patients do not develop either malignancies or Parkinson's disease, so there's a lot to learn there. But this fits then into the idea we are probably beyond the single drug treatment for Gaucher disease. In the beginning, it was give the drug, enzyme therapy, things got better, that's all you needed to do. Well, it's not all you need to do. And there are many patients who may need more than that, whether it's a combination of enzyme with some of the substrate reduction therapies, or potentially, as this story develops with the blockade of the complement system, a potential other approach here. How this exactly will fit in, I don't know, but this is a story that has now been taken up by a number of people. I know Dr. Mystery is working on part of this. How does this relate to the degree of disease you have? How does it relate to, how does it respond to therapy? How is it related to any particular manifestation in this disease? So this is a brand new aspect of Gaucher disease, and I thank you for your attention.
Thank you so much, Dr. Grabowski. What we're planning on doing today is taking questions at the end during a panel Q&A. So I'm sure that there are going to be questions for Dr. Grabowski as well as each of our other presenters this afternoon, and I ask you to try to hold them for when we get to our Q&A. At this point, we're going to clear our appetizers and begin to serve the entree. Dr. Sidransky, would you like to come up for a minute? Ladies and gentlemen, Dr. Sidransky had approached me a short time ago. She has a little announcement that she would like to make. Dr. Ellen Sidransky is on our medical advisory board, and she's affiliated with the NIH.
Welcome. It's great to see everybody here, and I don't really want to take up much time. The one thing I wanted to bring up was I work at the National Institutes of Health, the NIH, and I know that a lot of you over the last decades saw Dr. Brady, Dr. Behringer, other people at the NIH. At the moment, I'm responsible for evaluating patients with Gaucher disease, and somehow I inherited a lot of the samples that the Brady group collected over the years. I'm a little bit hesitant to use those samples, even though at the time patients provided consent to use the samples. But the tools that we have today are really different from the ones that people knew about when they were donating the samples, especially when with regard to genetics and the big amount of information that we get when we do genetic studies. So I just wanted to ask if any of you were seen at the NIH, if any of you had skin biopsies taken, and you probably, if you do, you still have this
disease. He was recruited to Cincinnati, where he was the A. Graham Mitchell Chair of Human Genetics and Director of Human Genetics at the Children's Hospital Research Foundation, as well as a professor in the departments of Molecular Genetics and Biochemistry and Pediatrics at the University of Cincinnati College of Medicine. During his research career, he has published over 340 scholarly works on the basic and clinical sciences of lysosomal storage and genetic diseases, while maintaining an active clinical and treatment programs in genetic diseases. He has continuously served on committees of the National Institutes of Health, the national and state governments, and many philanthropic and patient foundations, including serving on the medical advisory board of the National Gaucher Foundation. Since June of 2015, he holds the positions of Professor Emeritus of Pediatrics and Genetics at the Cincinnati Children's Hospital Research Foundation, is a consultant for and/or a member of scientific advisory boards for several biotech companies, and is the Chief Scientific Officer for Kniska Pharmaceuticals. I welcome you, and I now present Dr. Gregory Grabowski.
There it is. All right. Good morning. And I think it's great to be back in New York, although it took me 2.5 hours to get from JFK to my hotel yesterday afternoon. I have a feeling it may take me longer to get to the airport tonight. And hopefully my plane will leave. But it is great to be here. It's great to see many old friends, and I do mean older friends. That's important because you're here. And it's great to see you. And what I'd like to do today is I'm going to talk to you about something that's really quite cutting edge in this disease we call Gaucher disease. And I'm going to give you a little background on how we got to this position and how we're going to move forward on this. But this is really very new material. And I'm going to talk to you a bit about mice, because there's some things we're allowed to do in mice that we cannot do in humans, and they become important. So these are my connections, and I always put this up here because, shall we say, I think you all know who this refers to, but this disease is very complicated, very intertwined with how we live and feel and how it causes the disorder it does. These are some of the positions that I'm currently involved with. The one I left off of here is that I usually put as second, which is my mother and father gave me startup funds. But I work with a number of companies in their activities, and it's been really an educational experience for me in all different areas and therapeutic areas related to rare diseases. So I'm going to start with some lessons that we've learned over the last 25 or 30 years about lysosomal diseases, and in particular Gaucher disease. The assumption was that protein replacement, enzyme therapy, protein supplementation, enhancement could or should correct the disease at its origin. This is fundamentally true, because those people that don't have defects in these proteins or enzymes are fine. But then, if that is true, why do we have therapies and not cures? And that's because we really don't understand enough. We need to move beyond what do we need to do to move beyond the significant but somewhat limited effects of therapy to the total restoration of health? The other lessons are here. At the beginning, we didn't really care to understand, or didn't understand fully, the lysosome, which is the central organelle involved in Gaucher disease, and its function. And I'm going to take you through a little bit of that so that this isn't so opaque. And we still have a poorly detailed idea of what happens in time and in space in the body. And this is important because all these different organs that are involved in Gaucher disease are tied together, and they change differently at different times, whether it's your spleen, your liver, bone, or maybe even the brain. And we really had very little appreciation for some of the immune problems that are involved in Gaucher disease. Now, hopefully this will work well. So this is sort of where we come. There's this overproduction of immune molecules that really make your body change. Large liver, large spleen, your belly gets big, your bones change. They can even fracture as we move through this. And then we came up with this magnificent molecule that has this little thing on the end, which is a tag, and we put it in the bloodstream, and it runs around, and it finds itself directly going to these macrophages, which we call Gaucher cells, and it, just like the space station, it docks, it gets internalized, and it fixes what's going on in the cell. And it reduces this to normal cells with partial reversal of the effects of Gaucher disease. A lot of this that I showed you after we put this in the arm is magic. we really don't understand some of the details that happen as we put this enzyme into the body and it gets into these macrophages to make things better. And this is what we've started to think about when we look at what is happening. And I'm going to show you 3 or 4 very complicated slides, and they are meant to be complicated, not to put you off, but to bring you in to the complexity that we have to deal with in this disease. And the reason this is, we used to call Gaucher disease a lysosomal storage disease. Some of us are trying to move to the concept of the greater lysosomal system diseases because of the following. In 1983 or thereabouts, Christian de Duve came to Mount Sinai School of Medicine. He is the man who got a Nobel Prize for the discovery of lysosomes and their function. And I asked him as a junior faculty member, why do we have lysosomes? Why do we have these lysosomes inside the body, inside cells? And he thought for a minute and he said, so we don't have to live in our food. We can take it with us. Now, if you think about that, what's happening right now, you eat food, things go into your body. You're not sitting here swimming around in nutrients, but things are happening in your body. Your insulin changes, your glucose changes, your lipids change. All these things are going on dynamically, and that is really based on lysosomal function. And here's the first of the complicated slides. Up here, we have when you have increased nutrients, like we have now, the lysosome does things that it didn't do before. There's a compound that sits on a lysosomal membrane that shuts off making more lysosomes. It shuts off finding where other nutrients are, and it increases things in your body that will help store fats and sugars and so forth, and help digest it, so it adapts. But what happens when you're starving or under stress? This molecule that had sat on the lysosome comes off, you make more lysosomes, you increase the amount of fat that you burn up, and you increase some proteins that are involved in what is called autophagy. Autophagy means you eat yourself. So if you're starving, you have to eat yourself. And it does this. And the person who described this got a Nobel Prize last year. It shuts off making fats and making steroids and other kinds of things. So this is a central core in modulating metabolism through the body. And this is important. So it's not just something sitting there waiting for something to happen. It is actively involved. Many of you have complained to me about fatigue, about low energy. It's all part of this system. And we hadn't appreciated it before. Now, the initiators of Gaucher disease is the lack of the enzyme in the body and in the storage of the material that is there. But then what happens after initiation? When you first start out with the disease, it's pretty simple. You're pretty normal except for a few little things that are there. But as things go on, things become much more complicated. So we have a relatively simple beginning, which we call initiation. And then, just like an airplane, the body tolerates and adapts to certain deviations from normal. And it can handle it. And you've all been in airplanes and the plane goes, woo. But you're hoping it doesn't go, woo, because then it's gone. You lose control, and the control systems are gone. So here we can tolerate these deviations, these minor deviations. And then we have the evolution in a timed way of increasing complexity. And we start to engage other parts of this disease and other parts of lysosomal function into creating more and more complex abnormalities. If you read the literature that some of you are part of, from the beginning of enzyme therapy, you will see that there are statements that you cannot treat the bone disease in Gaucher. It's untreatable. That's because the initial patients we had gone too far, had gone too far with their disease process, and they are now into an irreversible stage. Now I'm going to try my little thing again here. There we are. So here we are again. The monocytes occur in bone marrow. They come out of bone marrow and they get distributed to various tissues in the body. And they become macrophages, and eventually they become Gaucher cells, and they're all different in different tissues. And the macrophage continues to eat things that it's supposed to. It's a big eater. But in Gaucher disease, it stores lipid, and it can't get rid of it, and it throws out all these red compounds that are these immunological molecules. And what do? They increase your metabolism. They increase your level of fatigue. They tell your body to eat more. It continues to move on and self-propagate itself. So it becomes a very, very self-propagating disease with all these manifestations that we talked about. But part of that is this system that I showed you here, and how the lysosome is disrupted. And then the next thing that happens is this disruption of the entire cellular system that controls energy in your body creates an immune response. And this immune response can lead to three things down here. Fancy terms: pyroptosis, apoptosis, and necroptosis. These are different ways that your body can kill cells. And they do it in
Good morning, everyone. Welcome. My name is Amy Blum. I am the Chief Operating Officer for the National Gaucher Foundation, and we are so thrilled to have you all here, physically present, as well as the many others who are tuning into the meeting today virtually through our Facebook live stream. So welcome to everyone. We have a very packed schedule today with lots of incredible information to share with you. So I'm going to start right away by introducing our keynote speaker, Dr. Gregory Grabowski. Dr. Grabowski received his MD from the University of Minnesota, where he also completed his residency in pediatrics and fellowship training in human genetics. He then established his research institution before moving to New York City and the Mount Sinai School of Medicine in 1979. Over the next 13 and a half years, he developed the world's largest clinic for patients affected with Gaucher disease and other lysosomal diseases. Dr. Grabowski established basic research and diagnostic laboratories for genetic diseases, as well as the first treatment center for enzyme therapy in Gaucher